right, thanks. It's great to see a lot of familiar faces this morning. So, on behalf of my co-chair, Jeremy Smith, and Soheil, I'd like to welcome you all to the FARIL International Symposium series on ankle fractures and syndesmosis. Furthermore, I'd like to thank all our moderators and speakers, and in particular, our keynote speaker, Dr. Bhandari, who's going to be joining us a little bit later this morning and talking about innovation. Over the past 6 years, the growth of FARIL has really been amazing under Soheil's leadership. And podiums, publications, grants are all very important, and that's kind of the metric that we oftentimes measure ourselves by. But what is harder to measure is influence, and how collaboration, the development of true friendships leads to this type of collaboration and advancing science and things like that. Really excited this morning to hear your all thoughts on ankle fractures and just share your ideas. So Soheil, I'll stop there. I'll keep it brief. If you want to address any housekeeping issues before I introduce the first session.
Thank you so much. Good morning, everyone. Good afternoon to those of you who are on the other side of the pound. Very happy to have all of you on board here today for our first virtual symposium. Just a couple of points. I just wanted to mention that this meeting is being recorded, so hopefully we will have it on our YouTube channel after this meeting, available for those who want to see it afterwards. Those who want to request for certificate, an email will be automatically sent to all participants after this meeting. So all of you will receive that certificate through email. But if you wanted to have a signed certificate by the chairs and the moderators, please feel free to email us, and we will try to accommodate as soon as possible. Nothing more to add to this, and hopefully we will have a good symposium. So I pass the tribune to the first group of our presenters, and Atta will share the screen. Thank you, Atta, so much. Thank you to all the moderators, presenters, and let's start.
Yep, so our first session is going to be on alignment and stability. Our moderators are my friend and colleague Bedri, who's an associate professor of orthopedics and traumatology in Turkey, as well as Dr. Arne Burssens, who is an associate professor at Ghent University in Belgium. So go ahead, guys.
Thanks a lot for the kind introduction. We're very honored to open this first session. We'll be focusing on alignment and stability, which I think is one of the key things in syndesmotic ankle lesions. I'm very honored also to co-host this session with Professor Karaismailoğlu. He's working as foot and ankle surgeon at the Cerrahpaşa University of Istanbul, and we've been working a lot on a lot of jointly projects, and I can say that he's really expert in this field and that he won numerous awards, so I'm glad that I can join this session as a moderator with him.
Hello everyone, it's my honor also to be joining this session, and thanks to Dr. Kwon and Dr. Smith for spearheading this, and also my friend Soheil for spearheading this initiative. It's a really great opportunity to share ideas, and I am also honored to co-host this session with my friend Dr. Arne, who is an associate professor in Ghent University, is a very well-known leader in our field in Europe also, and he is also the new president of International Weightbearing Society. So congratulations to him. So the first speaker will be Dr. Daniel Gus. He is a professor in Harvard Medical School and Mass General Hospital. He is a pioneer in his field, and he is also he's been served in a board of directors in AFAS, and also he is the director of a fellowship program in Mass General Harvard. So he will be giving us insights about the syndesmosis, and we are really curious to hear about that. Please, Dr. Gus.
Thank you, everyone, for this opportunity, and obviously it's the people on this call that make FARIL amazing, and Soheil, thanks for your leadership on this. And so I thought I'd start with the basics and just ankle fractures and the syndesmosis. So if we can just go to the next slide.
You have the control of the slides. Feel
Oh,
free
I thought we
to-
don't have control. I thought we centralized it. Okay, perfect. All right, no disclosures related to this talk. How do I go back? I don't quite sure how to control it
You can
since I'm
also
not sharing
use
my
your
screen.
you can also use your keyboard.
All right. I'm using the arrows and it's not going back. There. All right. All right, and so the goals of this is to diagnose syndesmotic instability, to explain the implications of malleolar fractures, which is the most common scenario where we see these. A note on reducing the syndesmosis and hardware choices, and then focusing on the ligaments that we don't often talk about when it comes to the syndesmosis, the collateral ligaments. And so key point number one is that underlying all of this is that making the diagnosis far outweighs the incremental clinical implications of fixation strategies. There's a reason a lot of our research has been focusing on diagnosing instability. And so this is a 28-year-old female who fell on uneven ground while traveling abroad. She underwent surgical fixation and then traveled back to the US to establish care. That was her initial picture, and then you see her at 3 months when she was evaluated by one of our colleagues, and then underwent a revision procedure. And then I got to meet her 1 year post-injury when she presented with this presentation. And this is a really tough scenario. What do you do with a young 28-year-old who walks into your clinic with this X-ray? This is another example. This is a 23-year-old playing football who presented for the first time 1 year after the initial procedure with this X-ray. And if you look at the CT scan, you can see that there's widening at the syndesmosis. And so again, these are tough scenarios where you're now in salvage mode, and that's where the critical part of diagnosing these early. How do you avoid these scenarios by neglecting to treat syndesmotic instability? This doesn't always happen with a fracture. This is a 27-year-old who fell on stairs and initially self-treated as a sprain. Presented about 7 weeks, or this is an X-ray originally from 7 weeks post-injury where you can start seeing heterotopic ossification at the syndesmosis. There isn't a proximal fibular fracture associated with this, so this is not a Mason-Neuve per se. And then presented to my clinic about 4 months post-injury, and with this X-ray. And again, when you get a CT scan, you start seeing the asymmetry at the distal tibiofibular articulation. And at this point, thankfully, it was early enough that you can perform a salvage procedure with still maintenance of the joint. But again, how do you diagnose these early? And that's the key. Its diagnosis is way more important than any fixation strategy. And the stability of the syndesmosis, there is a bony component, especially in the 75% that are concave, but it's largely dependent on ligamentous structures, both anteriorly and posteriorly, as well as the IOL. And the critical part of all of this is separating injury from instability. And some of our initial arthroscopic research demonstrated that all 3 syndesmotic ligaments must be injured to destabilize the syndesmosis, but they're not the only contributor. You can have a partial injury to the AITFL and IOL, and then if you also have a concomitant deltoid injury or even a lateral ligament injury, that can destabilize the syndesmosis. And the thought about that is that it has to do with the fact that ultimately what the syndesmosis is doing is maintaining the mortise by keeping the relationship between the tibia and the fibula. And it can do so directly through the traditional 3 syndesmotic ligaments, but it can also do so through the collaterals because they attach to the talus and that can bind the tibia to the fibula through the talus. Diagnosing syndesmotic instability out of the OR is multifactorial. Physical exam is always critical, and that's where I urge all the trainees with every examination do a proximal squeeze. You can do fibular shock or external rotation. A lot of these can be limited by pain at early presentation. You can get radiographs, often bilateral, though this has been shown to be low sensitivity. And a lot of our work in weight-bearing CT builds on the fact that the CT has a number of advantages that are critical, one being three-dimensional, the other being allowing contralateral comparison, and the other being under physiologic load. Ultrasound also is exciting because it allows all of those at the bedside without radiation exposure. And inside the OR, we often rely on stress maneuvers that aren't accessible in clinic. The traditional cotton maneuver is a coronal plane pull. It's a lot more force than people think. 100 Newton translates to about 22.5 pounds, applied 5 centimeters from the fibular tip, and you're looking for about 3 millimeters of diastasis. Based on our research, what I've increasingly relied on is actually sagittal plane translation, where both an A to P and P to A force can result in more than 2 millimeters of translation. And that's been shown by folks at FARIL to be more sensitive than coronal plane displacement. The key technique tip is, if you're going to do this, make sure to apply the force above your fracture fixation, not distal to the fibula you just fixed. The key point number 2 is that syndesmotic fixation cannot overcome malreduction of the malleolus. A lot of the revision cases we do pertain not to lack of diagnosis, but also malleolar malreduction. And so this is the 20-year-old college student who jumped out of a second-story window onto a snowbank. And she was fixed locally, and this is the fluoroscopic images. And then she presents to my clinic about a year later with these radiographs. And so what you can see is that we can't overcome malreduction of the fibula. No amount of syndesmotic fixation can overcome it. And again, now we're forced into salvage procedures with fibular osteotomies trying to regain alignment. Because of that, we also, reducing the syndesmosis, we chase the fractures pretty high. One of the best ways to avoid syndesmotic malreduction is, and to make sure that we get enough fibular length, is to get anatomic reduction at the site of fracture. The key point number 3 is remember the ligamentous attachment points. When we're repairing the bones, what we're actually also repairing is the ligamentous attachment points that attach to the fragments that are undergoing fixation. And so these are interrelated. And so when you think about the multifactorial aspects of fracture fixation, you can actually envision the ligaments that might be affected, the deltoid medially, the IOL more superiorly, and even these small avulsions that you see on CT anteriorly, that's the AITFL, as well as the posterior malleolus in the relation to the PITFL. And that's the part where, as we're fixing the fractures, we're also contributing to syndesmotic stabilization indirectly. And the real question that often arises when it comes to this is, when does one fix the posterior malleolus? And I know there'll be lectures about that later by Dr. Smith, but there's a budding literature on this as well. And the real reasons to fix it are twofold. One is to stabilize the ankle joint, but the other is to stabilize the syndesmosis by virtue of the PITFL attachment point. And so, for example, this is a woman that had a trimalleolar fracture, and by virtue of stabilizing the posterior malleolus, you can actually normalize and stabilize the syndesmosis, as you can see by the stress radiograph to the left. The other key point is that it's open reduction internal fixation, not just internal fixation. And so the key when we're reducing the syndesmosis is it is a reduction maneuver. It's not the thing that you do at the end of the case after you fix the fractures and you're now just about to close. And so there's a lot of strategies that help with this. One is directly visualizing the anterior incisura and its relationship to the anterior fibula. That significantly decreases the malreduction rates. Consider preoperatively and before draping in the OR a perfect lateral of the contralateral side and measuring the posterior malleolus to posterior fibula distance. I think where this becomes really, really important are in displaced Mason-Neuve fractures, where you won't have the benefit of a perfect reduction of a fibular fracture to guide your syndesmotic reduction. And then also tine position. This is a reduction, so I have a very low threshold to getting a contralateral CT, and you have to think about where the medial tine sits, and then you can also use lag screw techniques rather than a clamp. The caveats is that when we're judging malreduction, that alone is not to be taken for granted. A lot of these articles have thresholds of 1 to 2 millimeters when they talk about this. And so the question about how much that much matters and the ability to measure that apart from CT. The rates of malreduction with the distal tibiofibular joint may also normalize after screw breakage when you're choosing hardware. So it's not automatic that flexible fixation is better than rigid. And while some studies show poor clinical outcomes with malreductions, others don't, and they're often using non-validated scales. And so that goes back to the fact that diagnosis is more important than anything. The key point number 5 is that rigid versus flexible fixation is probably outweighed by the decision to fix. And so that's where both have excellent outcomes. Studies have shown improved outcomes with suture buttons, but often with unvalidated scales, and the benefits may be incremental. Screws have advantages too, right? They're better at maintaining fibular length and sagittal fixation. You may be able to, and sagittal stability. You may be able to overcome some, but not all of this with diverging the suture buttons, especially because if you start diverging posterior medially, important structures lie there, and nothing can overcome malleolar or articular malreduction. The key point number 6 is it's better to overfix than underfix. This is a US Marine that came in with this ankle about 2 months out. We performed an osteotomy and realigned him. He walks into clinic at his 2-week visit without a splint, and he got revised. And then lastly, the deltoid complex contributes to syndesmotic stability, as I mentioned earlier about the collateral ligaments. And this is where I think Amgad is going to be talking about this and the role for fixing the deltoid. But the times that I think it should especially be considered is that if after syndesmotic fixation, you're still getting talar tilt during external rotation stress. And this is how I often base my decisions, but I realize this is a growing literature. And so in summary, when it comes to the syndesmosis, making the diagnosis is by far the most critical. Independent of the approach to the syndesmosis, nothing can overcome malleolar or articular malreduction, and the most common thing we see is not maintaining fibular length. Fixing the bony ligamentous attachment points is equivalent in some ways to fixing the ligaments, and that's where a lot of the literature about posterior malleolar fixation in the syndesmosis comes from. The key when you are reducing the syndesmosis is that it is the reduction. Consider looking at the anterior incisura, making sure that the medial position, if you are using a clamp, is anterior medial or at least correlates with a contralateral CT reduction vector, and that you get a perfect lateral of the contralateral side when you know you're not going to get the benefit of perfect fracture alignment in the field of fixation. There may be an incremental benefit to incremental fixation, and you may consider diverging suture buttons. It's better to overfix than underfix the syndesmosis. And then consider the deltoid complex with an external rotation stress view after you fix your syndesmosis. And so, thank you all.
Thanks a lot, Professor Gus, for sharing those impressive cases that are indeed very hard to handle. The key points were relevant for us in treating our next syndesmotic ankle lesions, so we'll be very looking forward to that. We have a small announcement for a change in the program. Professor Varias will be called into the clinic, so he'll give his talk now, and then after Dr. Pfeiffer will give his talk, but he will be coming back for the questions during the discussion, and my co-chair will introduce the next speaker. Thank you.
Yeah, it's my honor to introduce Dr. Greg Varias, who's working in the foot and ankle department of Mass General Hospital, and he is also the director of sports medicine department, and also he had team orthopedist in Northeastern University. So he has a lot of experience on this subject. So we will be really happy to have his insights on it. Please, Dr. Greg.
It's a pleasure to be here. It's the who's who in FARIL, which is great to see everybody. So we're going to discuss the needle arthroscopy and ultrasound for unstable ankle. And really, ultrasound, we have to give credit to our FARIL International folks for the development of that program. Let's see. Okay. There we go. Nothing related to this talk. We're just going to... we're going to discuss recent literature and also what's new. So really, I think the factors in play for syndesmosis have to be discussed first. So we talk about injury, but not instability. And so if you have instability, you're fixing it. Injury doesn't mean it has to be fixed. So we'll have lots of patients that have visible injury to structures that we see arthroscopically or by ultrasound or by MRI, but they're not unstable. And so for pre-op workup, I sort of go off of this anterior syndesmotic tenderness around 5 centimeters proximal to the joint and getting axial views on CAT scans and MRIs, or do dynamic testing, which is either fluoroscopy, ultrasound, or dynamic testing with a needle scope or an arthroscope. So I think most of us on this call sort of have been going more towards weight-bearing CT scan over MRI. If you can choose just one exam, in our higher level athletes, we tend to get both because they do show a little bit more prognosis as well. And if you're not sure, I think it's totally acceptable to do an exam under anesthesia, which is an arthroscopy in the OR. But if your center allows you to do procedure room needle arthroscopy, then that is a great option and probably is equal to, if not better than, MRI and CT scan. So for ankle instability, just lateral medial ligament, in addition, we want to know how long patients have had symptoms, where they're having pain, what induces the instability, and if they have any collagen disorders, Ehlers-Danlos, Marfan's, or anything else. And then do they have impingement or other tendon issues? Because that gets included in these whole workups. And a lot of the needle arthroscopy literature is actually more for impingement reasons and what's been done at NYU. So our group, Bart and Clan, when FARIL was getting started, did so much work on arthroscopic evaluation with cadavers. So just to kind of review the things that I take away from this is you're supposed to do the stress maneuvers off of traction, which means taking down traction if you use it. But if you use something like Curlix or no traction, then you don't have to worry about that. And then the cadaveric roll of sagittal plane was 2 millimeters of translation. And you don't have a comparison side when you're doing a scope, unlike with weight-bearing CT scan. So you really don't know where the person sits on the other side. But when you're doing ultrasound, you actually can check for that. And then coronal plane, you look at the posterior margin of the incisura is more sensitive than the anterior margin for diagnosis. And the anterior margin is only significant when there was a combined syndesmosis and deltoid transection. And then we go to Guyton's major study, which basically wanted to improve making sure we're not over-treating patients. So initially, people use a 2 millimeter ball or probe to see if you could fit it into the syndesmosis for coronal testing. But they felt like after cadaveric work that a 3 millimeter ball is likely better. And so I use a 2.9 shaver. I don't have a 3.3 millimeter ball available to me, and I don't think it's worth it. The 0.1 millimeter difference probably isn't going to make or break it for me, but that's what I do. So just to kind of go through how I do this, this is a picture of an actual needle scope in the deltoid area. Arthroscopic anterior medial, anterior lateral portals, test off traction, look for hypermotion in the sagittal plane and easy penetrance of the 2.9 shaver into the syndesmosis. I also look for these sort of ramp lesions on the PITFL where you'll see it avulsed off of the tibial side with a piece of cartilage. And so it actually creates a small little osteochondral injury at that spot. It's not a weight-bearing zone, but it is a good chunk of cartilage with some bone usually that rips off. And so then if you know you have your AITFL injured, your interosseous membrane is injured, and your PITFL is avulsed, that's a little higher inclination that there's a problem there. So why a needle scope? It's a smaller diameter scope, so the incision is a little bit smaller. So not to talk about companies, but I think it's important to talk about companies with this because of what's available. So in the US right now, to my knowledge, there's two main companies. There's the My Eye with Trice and the Nanoscope with Arthrex. And there's probably some other options I'm just not aware of. But there's 0 degree is the Nanoscope, and then the Trice has 15 and 25 degree option as well that you can sort of flip to while you're in there, which is kind of nice. But I think most of the literature is based off of the Arthrex product. So people actually will have whole talks that just say nanoscope, but in reality, it's any needle scope technology. So it can be done in the office under local anesthesia. That's this Iona that's been popularized by John Kennedy over at NYU. Diagnostic and therapeutic interventions can be done at the same time, which is nice. Lower costs because it's not done in an operating room, so you have less staff and less anesthesia costs. Patients can be awake and actually be watching you do the procedure, which is kind of cool. And you can treat pathologies that an MRI and ultrasound can't. So those are the pros to it. The cons is that it's still a procedure. So it's invasive. You can do biologics at the same time, PRP, autograft adipose, if you believe in that stuff. You can treat ankle impingement, anterior or posterior, osteochondral lesions. Needle scopes are also really good for hallux rigidus, in my opinion. Lateral ligament repairs and tendoscopy. Tendoscopy is a great thing for a needle scope, in my opinion, because you don't really need high volume fluid. And you could use the syringe aspect for inflow, outflow, versus having to set up a pump like Dr. Kennedy does in his. So they looked at Iona for 31 patients with ankle impingement, and they had, the main outcome was 94% expressed willingness to undergo the same procedure again if it was needed. They reported lower pain reduction, low complications, and excellent PROMIS scores, high return to work or sport at a quick rate. Then this was kind of duplicated with posterior impingement with 10 patients, and they had returned to play at 4.1 weeks, which is very quick for that type of procedure, and returned to work at 3.4 days, and the Iona experience was a 9.5 out of 10. So not really a validated thing, but awesome to hear. So just a quick case of an Ehlers-Danlos patient that was 19 that I've shared a couple different talks, but she had a modified Brostrom and an ankle scope. And then they had a discussion about allografts. I like to do allografts for all my Ehlers-Danlos patients. And then she really didn't have any syndesmotic symptoms pre-op. But when we tested her, it's a little grainy, I'm sorry. But I'm just pushing on the fibula. And you can see that she's sliding around like 3-4 millimeters. And so that would not have been noticed if we didn't do the scope. And we probably would have just done the lateral ligament on her, but instead we added in the syndesmosis suture button construct. Another case here, 39-year-old female with chronic ankle instability from sliding into second base playing softball. Doesn't really look like much. We did a weight-bearing CT scan, and you can see this large gapping in her syndesmosis, an easy passage of a 3-millimeter device. So she got fixed with suture buttons and did well. That's sagittal testing. And let's talk about point of care ultrasound. So there's people that are much better experts than me at this on the talk right now, but it's a great rapid way to diagnose. And I love this. I bring my company branded butterfly to all the Northeastern hockey games, and we're ultrasounding people left and right in there because it's wonderful to be able to give people diagnosis quickly. We do see a fair amount of high ankle sprains in hockey. So you can detect diffusion, synovitis, and rule out fractures and tendon tears and things like that. Perineal subluxation is a great thing for ultrasound as well. It's nice for rib fractures as well, surprisingly. And if you're ER trained and you can do a fast exam, you can check out a lot of people's bellies in the training room, which is cool, saving a lot of ER trips. We started off with Norcha back a long time ago, and this was published in 2020. We were looking at normal variations in motion of the syndesmosis, and what we really kind of focused in on was sagittal fibula translation, and sagittal translation that was normal was around 1 millimeter of anterior to posterior, and posterior to anterior was 0.49. And so that's sort of our basis for what the normal is. And it was reliable when tested amongst multiple providers and retested. So we got very creative as a group with smarter people than me leading the way. So we wanted to look at reproducibility and reliability of ultrasound for medial ankle instability. And it was assessed in the sort of the gravity type stress position, and with 50 patients without previous injury, and the distances were measured. And so Girowatt was kind of the rock star of this whole project. Use of dynamic stress ultrasound to measure the medial clear space was reliable, and you know, the difference wasn't that great in terms of amongst providers. So stress exams using ultrasound were felt to be radiation-free, non-invasive, low cost, and in the point-of-care setting. So if you're really good at ultrasound, you can basically replace the fluoro for that. Using dynamic portable ultrasound for the lateral instability, we did a cadaveric model comparing it with fluoroscopy. Sorry, I'm not used to this team stuff. Also looking at fluoroscopic assessment of the effect of syndesmotic injury on lateral ankle instability using cadaver models. Both groups, the assessment was first done with all syndesmotic and ankle ligaments were intact, and later with sequential transection. And we basically, and Rohan here led the charge with syndesmotic injury does not affect lateral ankle stability, but lateral ankle instability appears after injury to all syndesmotic ligaments and ATFL. And so things to sort of say you might have to fix more than one, so you need to be on alert to do that when you're in the operating room. And then our dynamic ultrasonography assessment of the impact of syndesmotic injury on lateral ankle instability. 16 fresh cadavers were used, both groups. Resections were done and things were evaluated. And same, I don't know how it's repeating, sorry. All right, so in summary, the needle arthroscopy can be done in the office or OR setting and allows for treatment of pathology. The ultrasound is great for a non-invasive option. It's cheap, aside from the probe, which now one of the companies is not letting you use probes that are old, so that's a disappointment. So we have to do a better job figuring out which company is going to continue to support their software going forward, because the company we did all the studies with is now not using those probes from a couple years ago, starting in December. And diagnosis is based on ultrasonographer skill, so it's not something that just anyone can do. You have to actually put some effort in, and you should start evaluating normal patients so that when you see problems, you find it. All right, and that's it for me.
Thank you, Dr. Greg. It was a really great talk, and it's really nice to see how the new technologies can be applied into our practice. So my co-chair, Arne, will be introducing our next speaker, who's a friend of mine also.
Thank you, Bedri. It's now my great pleasure to introduce my friend and colleague, Dr. Matthias Pfeiffer. He works as orthopedic surgeon at Ghent University Hospital, and his work focuses on advanced imaging and biomechanics of the foot and ankle, mainly using weight-bearing CT. That was also the topic for his PhD, which he recently defended. And he's also collaborating a lot with the joint projects that we have with the FARIL Lab. So really looking forward to his talk.
Hi, good morning, everyone there. Congratulations to the organizing committee for organizing such an interesting conference, and of course for the invitation. My name is Dr. Matthias Pfeiffer, as Arne already suggested. I'm currently a foot and ankle fellow, and I work together with Arne Burssens in the University Hospital of Ghent. I was at FARIL a couple of years ago, and I'm still missing it every day. It has become a wonderful group of friends, and I'm proud to see it grow day by day. So thank you. Okay, let's go to the slides. Let's see if this works. Okay, first of all, I have no disclosures, and I wanted to start off with a case, clinical case. So this was a patient of 64 years old who has sustained a Mazeneux fracture on the left side. He was treated in another hospital. As you can clearly see, there was an displacement of the fibula of the talus with a widened mortise, of course. They did an open reduction and internal fixation and stabilized it with one tightrope. And then we could see on the supine x-ray, of course, that there was a good restoration of the ankle mortise and also of the syndesmotic distance. But after 6 weeks, she came in, had a little bit more pain, and we took another x-ray, and we could not definitely see a clear increase of syndesmotic space, but increased in pain suggested there was something wrong. The mortise was still quite symmetrical, but we needed to do something more to see if she had any recurrent problems of her syndesmosis. So that's why in our hospital we use quite a lot of weight-bearing CT, and as already been mentioned by Dr. Gus, of course, with this technology, the patient is allowed to bear weight while a CT scan of the foot and the ankle is performed. The novel technique is getting increasingly more popular, as you can see in the PubMed results that I tried to search in the beginning of this year. And for me, I think the true merit lies in the possibility to have a three-dimensional understanding of the ankle joint during physiological load of the patient. Where we had to rely on these 2D images before, we can now see the three-dimensional view of the ankle bones without obscurance and superimposition of the foot and ankle bones. So one of the first things that we look into when we check the weight-bearing CT is the bony analysis, and we like to do this in 3 dimensions. So for this, we have developed a deep learning segmentation framework to visualize and to model the weight-bearing CT scans with their separate bony structures. So we have each bony structure as a separate entity. Then we transfer them to a 3-dimensional coordinate system after we could automatically detect all the landmarks on the bones. And if we have all the landmarks, we can do quickly some measurements that are transferred from the 2-dimensional space to the 3-dimensional space on the anterior tibiofibular distance, the posterior tibiofibular distance, and all the angles that we are known to in the 2D space. The second thing that we can look into is the soft tissues. So for this, we have developed and validated an algorithm for prediction, but also for modeling of the ligamentous structures based on the bony anatomy. And in this type of analysis, we have seen that there is, in syndesmotic injuries, we have mostly seen an increase of the anterior inferior tibiofibular ligament distance. So this would be a rupture or a strong elongation of this ligament, typically resulting in an external rotation injury of the fibula, but also anterior widening. Then the third thing we can look into is about the cartilage stress of the ankle. For this, together with Dr. Kwon and the whole FARIL team, we have developed a technique for automated cartilage segmentation and cartilage prediction, and we have developed a technique for finite element analysis on these foot and ankle bones, so we can know the mechanical behavior in the tibio-talar joints. So after applying body weight, we can try to look into. Does it work? We can look into the cartilage stress on the tibio-talar joint after using the finite element analysis, where we can clearly see the distribution of the contact stress in the talus, but also on the tibia. For this, we wanted to look into the 3-dimensional displacement of the ankle joint, as mostly it has been investigated by Ramsey and colleagues about a lateral translation, but we also wanted to look into the 3-dimensional deformity of the ankle joint. And we thought that maybe external rotation or valgus and varus tilting would increase in contact stress even more than only lateral translation. And as we can see in the results, there was an increase in contact stress that occurs more if there was external rotation of the ankle, more than if there was only an isolated lateral translation. So I think it's very important that we look into the 3-dimensional deformity of the talus and not only in lateral translation as we measure the medial clear space in these ankles, but we should look into, is there also an external rotation? Maybe if the fibula moves posteriorly and externally rotates, the talus can also move posteriorly and externally rotates, and this gives more contact stress than only an isolated lateral translation. So this is something we need to look into. Then another study that we did together with Dr. Gus, leading this study, and the whole FARIL team, of course, was to look into stable Weber-B fractures. For this, we took 33 patients with a stable Weber-B fracture. We developed the 3D models in these fractures, and then we looked into the syndesmotic widening, but also the medial clear space widening. And in these patients, there was no increase of the distance in the tibiofibular clear space and also no increase in the medial gutter. So these were symmetrical, stable, congruent Weber B fractures. And these in our study did not result in an increase of contact stress on the tibio-talar joint. So from a theoretical mechanical point of view, maybe these patients would not need surgery or not need osteosynthesis, of course, from a mechanical point of view. Then another thing that we need to look into are more the subtle ligamentous lesions, as these can be quite difficult to diagnose. As already been shown by Arne Burssens, that maybe axial loading alone is not enough to displace the syndesmosis in only a purely ligamentous lesion, even if the AITFL, the PITFL, and the deltoid is sectioned on a cadaver. There was no clear increase of syndesmotic distance. But when applying external torque to the ankle, there was a clear increase of the increase of tibiofibular clear space widening, but also of posterior translation and external rotation of the fibula. So we had the idea that maybe we should use external rotation stress as well in a clinical setting to diagnose these truly subtle lesions in which there are only a couple of ligaments ruptured. So that's why we set up a clinical study in which we included patients with subtle syndesmotic injury diagnosed on an MRI scan. We put them into the weight-bearing CT, first after only axial loading, and secondly also after performing internal rotation stress of the tibia to mimic the external rotation stress on the talus. And in these patients, for example, if we look only into the actual weight-bearing CT slices, we could not see a clear difference in tibiofibular widening. This is difficult to see and we can measure, but it's always difficult to know if we are in the exact axial slice as in the contralateral side. So when we put these patients into the three-dimensional space, we see no clear displacement of the tibiofibular clear space during neutral, but after performing stress, we could clearly see in this left ankle that there was an increase in tibiofibular distance. So after applying the stress, we could now diagnose the subtle ligamentous lesion of the syndesmosis, and we would do an arthroscopy in this case. Maybe if there was no external rotation or no widening, this patient would not need arthroscopy and we could prevent this. Then this is also building further on this previous research where we could clearly see in the syndesmotic lesion a posterior translation of the fibula and also external rotation in comparison to the neutral side where there is no posterior translation or almost no displacement of the fibula after applying stress. So let's go back to the case that I discussed before. We had this patient with a mesonew fracture which had a clear displacement of the fibula and of the mortise of the ankle. This patient had one syndesmotic tightrope was been placed, but after follow-up after 6 weeks, there was kind of an increase in syndesmotic distance and patient having pain. So we decided to put this patient into the weight-bearing CT scan after we could clearly see the displacement, but also of the increase of the medial gutter and the valgus tilting of the talus. So the tightrope has definitely been failed and probably elongated. And now we can use our bony analysis first to look into the displacement of the fibula, the talus, and have all the measurements. So we know there is a shortening of the fibular length. We know that there is an increase in anterior but also posterior tibiofibular distance. So that can guide also our correction and our reduction in the operating theater. So we know we have to give length to the fibula and we know we need to closen up the anterior but also the posterior space of the tibiofibular clear space. We can also check if this patient would have increased contact stress to know if this is a patient who can have osteoarthritis in the long term. And in this patient, we could clearly see an accumulation of contact stress on the lateral side of the tibio-talar joint. So because of the widening and the valgus tilt of the ankle, of course. So we definitely need to correct this in our operating theater. Thank you.
Thank you very much for sharing these imaging techniques. Very learningful. Indeed, also important diagnosing the subtle in the syndesmotic lesions aside from the frank one that you showed. I think now we have some time for questions. Would there be any questions for the first speaker, Professor Gus on his talk regarding syndesmotic instability and ankle fractures.
I just quick thing. I just have a. I know we're ending at 8. Matthias, I wanted to ask you, how do you decide what is clinically relevant? One of the issues we've always had with our syndesmotic studies is the fact that these we're using statistical differences, but then there's the next leap to correlate it with clinicals. So, for example, the external rotation CT that you showed, how do you decide if that needs surgical fixation? The analogy is if you could do a drawer maneuver in someone after an ankle sprain, they would probably be positive if they could endure it, and yet we're not fixing the majority of lateral ankle sprains. Help me understand how y'all are thinking about that.
Yeah, that's a perfect key point, and that's for now something we cannot answer. That's a pity, of course. For that, I think we need long-term follow-up, of course, and we need probably a good but difficult ethical study. And in each patient, we do every exam. So we do an X-ray, we do the Weightbearing CT, but also the arthroscopy. And then decide probably, because the arthroscopy is still the gold standard, to know if we have to fix this syndesmosis or not during the arthroscopy. And then follow up these patients for a long term. And then in the end, we could see if in some patients we did not need to have restored the syndesmosis and stabilize it, if these patients will do well, and then see their clinical results, but also their results on the external rotation stress during the Weightbearing CT. So that's always the difficult question, and something I cannot answer for now. I'm afraid, but yeah, that's truly the goal. I think we need to go to have this perfect study, and we could correlate all the exams together to know if patients really need stabilization or not. But that's hopefully something for the future. But perfect point. Thank you.
Thank you, Professor Gus, for this interesting question. I might also have one for you. You showed impressive cases with post-traumatic deformities after the syndesmotic injury, and you were showing some corrective osteotomies. And I was curious, you're correcting the length, but when there's the malunion, do you also look for rotational issues? And do you base this on the contralateral side, or do you say this is mostly something I look for during the surgery? Or would you have some tip for us that could be helpful in treating those?
Yeah, I mean, so we're looking for both. You're 100% right. We get contralateral x-rays. We also generally get a contralateral weight-bearing CT scan. And when you make these osteotomies, they're not transverse. They're sort of almost like a scarf osteotomy. At least that's how I do it at the fibula. And then you're getting both length as well as rotation. You're rotating the fibula as well to close down the mortise.
Okay, thank you very much. I think my co-chair will ask some question for
yeah, so for our next speaker, Dr. Greg Warriors, if there's any question, you can raise your hand or you just open the mic. But I will just, in the meantime, I will ask a question to Dr. Greg. So how is it convenient in a outpatient setting to do a needle scope? Like in some cases, like the patients are more like kind of scared of such things, and sometimes and also, how is your setup? Do you apply any kind of local anesthesia? How often do you really feel required to do some kind of needle scope? So what is your experience on that? Because I'm scared of using it at outpatient setting.
So unfortunately, we don't have the availability to do it at our center, but one of our fellows sort of did the fellowship, and so they routinely do it at NYU, and I think they're starting to do it at Yale, but we don't have the procedure room in the US for it because of the cost. So I think if your OR is available, it's probably better to even use the scope in the operating room because you can convert things. I think one of the worst things that you can do is have to tell a patient like, oh, we need to do this, but we already did your scope, but we need to take you back and do something. If it's better, just take care of all of it. So if you have OR time, it's probably just better to do it in the operating, even if you're doing it under a local in the operating room, so you can change it. But for certain places, that is a great option. And for certain things, it might be fine. Like I do a fair amount of perineal sheath injections and things like that, and I would probably do the nanoscope for that in the office. But yeah, we don't, unfortunately, although I gave the talk on it, and I used the scope a lot in the operating room. I just don't use it in the clinic setting right now because of availability.
Okay.
That's the case all across most of the United States.
Mm-hmm. Mm-hmm. Dr. Kwon, please.
Yeah, thanks. So I guess this is a question for Dr. Gus and Matthias, but really for the whole group, because we have some kind of the world experts on weight-bearing CT here. So, you know, I thought that the study you guys did was super interesting about stable Weber Bs. And I was a little surprised by your findings that the contact pressure and area were similar on both sides. We did a study looking at stable Weber Bs, and we had non-weight-bearing bilateral CT scan after they healed. And we found that the medial clear space was 0.7 millimeters wider than the uninjured side. And Kadakia did a study. I'm not sure if he published it, but he looked at a SCR2, a stable Weber B model, and found that the kinematics are actually abnormal compared to a quote unquote normal ankle. And so I guess my question is, and I've always kind of contemplated this, is weight-bearing CT the modality we should really be using? Because, you know, we all know that when patients stand, it has the ability to normalize a slightly malaligned mortise. And so, you know, I'm wondering if you guys might have gotten different results if you used the non-weight-bearing CT scan. But anyway, tell me your thoughts on that.
Dr. Gus,
go ahead. Yeah, go ahead.
I think you're completely right. And I think, of course, because, yeah, it's not the ball and socket joint, of course, but it has some congruence. And I think if you stand on, the talus can seem to soak its way into the distal tibia. I think that's true. Also, the weight-bearing CT, as I showed earlier, is only extra loading, of course. And I think probably if you really look into kinematics also while walking and maybe while running or doing some different movements, probably these subtle changes become more pronounced and probably could result in some change. For this, we found no change in the medial clear space and also the syndesmotic clear space, but maybe we took other patients, of course, and these were more stable. Will probably only be SIR2A in fact injuries. But I think I agree, if you're lying supine and your ankle has more mobility, maybe some subtle changes, or the deltoid is really not tensioned, and maybe legs could displace your talus more than in weight-bearing CT scans. But then the question is, if you're lying supine, you're not loading your ankle, of course. So yeah, of course, we want to know when it's loading. That's when I think the post-traumatic arthritis occurs, not when lying down. So yeah, it's a difficult question, but I totally agree.
Maybe I will have a little question for Matthias also. So do you think, do we have any kind of standard protocol for like having a weight-bearing CT in a patient that we suspect syndesmotic injury, like one leg standing, two legs standing, external rotated? Do we have anything like that right now, or do you think we will have that standard protocol in the near future? What do you think about it?
We mostly do just bilateral standing, but then you're only putting half of the weight, of course. And it's been like a lot of things has been said about this, because we never know how much weight they actually put on their foot. I think we should have like a scale or maybe like a force pad underneath in the weight-bearing CT to really know how much weight, and they're not compensating on the contralateral side. For fractures, we have not dared to do the external rotation stress yet. I don't know if it's probably difficult because they are in so much pain to really do an external rotation stress themselves. in other centers, they use a lot of gravity stress, of course, and manual stress in these fractures to know the medial clear space. I think that's valuable, of course, but we have not seen to incorporate this already into the weight-bearing CT. But I think we should go for something standardized, of course, that we all speak the same language.
Thank you. Dr. Kyoto, please.
Hey, thank you. Daniel, question and a great talk, thank you. These high fibular fractures, they're not mesoneus, but mid-shafts. Are you of the opinion that we should be reducing these with plate fixation, kind of your key point to over-reduction? Sometimes I see patients put distal screws or distal plates and not go up and plate those. And I know we talked about this in our indications conference, but I think after your talk, I'm leaning towards definitively fixing those with the ORAF.
Yeah, I would agree. I have a low threshold for going up there, including separate incisions. You do have to obviously be careful about the SPN and dissect it out. But the motor supply comes proximal, so that protects you a little bit. I think the harder part that even builds on that question is the fact that what happens when that is a very comminuted fracture that doesn't allow you to get absolute stability. So my question is always, am I able to get some degree of anatomic read up high that will then facilitate the syndesmosis, and then I will fix it? If it's comminuted and it's going to and long, and I'm going to need a long bridge plate anyway, and especially if that starts extending very, very high towards the common perineal, that's when I'll rely on indirect means. But then I think it doubles the onus on the surgeon to have contralateral films, get a perfect lateral. Since you're relying on indirect now syndesmotic reduction, I think the opportunity for fixing the fibula short or malreducing. And then I do transparently think the literature about flexible fixation applies less. I struggle with the idea of a flexible device maintaining length in sagittal stability, and in those kind of cases, I will gravitate towards screws. And then the only other part on flexible fixation, by the way, Matthias, that example you showed, that what happened is the button eroded into the fibula, right? And so transparently, if I'm going to use any sort of flexible fixation, or a screw for that matter, I use a plate construct too, just a short plate to act as a functional washer. So you're not reliant on the cortical strength of the fibula to sort of maintain the reduction.
Thanks a lot, Professor Gus and Professor Kyoto, for these interesting remarks. I think we can consider them as closing remarks of this session on alignment and stability. It is now my greatest honor to give back the microphone to Professor Kwon, who will introduce our next speaker. Thank you very much.
You know, it is my honor and pleasure to have Dr. Mohit Bhandari here as our keynote speaker. We had him up recently at MGH at Harvard, and you know, I've heard him talk about 5 to 6 times, and every time I hear Dr. Bhandari talk, not only do I learn something, but it just stimulates a whole different thought process. His accomplishments are listed here, but you know, I won't read the slide. But we're really happy to have you here, Mo, and thanks for joining us.
No, and again, I really apologize. I've been trying for literally since 7:45 to log in, so it's probably on my end, but I do apologize. It's the first time it's happened to me as well. If I can get privileges to share my screen, I'll put my slides up.
Please go ahead.
So I'm going to share with you, really, it's a short, so I've kept it about 15 minutes or so. And I'm hoping, okay, sorry. I'm hoping that you'll find this at least moderately helpful. It's been really important to me to be thinking about how we move with respect to ideas and creativity. And at our institution, we've really gone all in on this. Largely because we're in a very unique time in our period. The one thing I will also tell you up front is I don't use AI. I mean, certainly haven't used it for development of this. Well, I absolutely will be using AI in my lifetime, but certainly hasn't been something that I've been using for my own creative slide development or anything. So anything on here is really for me. I haven't used AI to develop this. What's really interesting, and I suspect you're all following to some degree what's happening with the Nobel Prize announcements, but literally last week, we identified, you know, a creative disruption as being worthy of a Nobel Prize in economics. And because of that, and I'm sorry, I don't know what's going on with Microsoft now. It's all working here. But anyways, so they basically have been given, they have basically been given a Nobel Prize for describing how economic growth comes from both creative innovations that disrupt existing technologies. And the truth of the matter is that anytime you do something novel and disruptive, for the most part, it is going to lead to a change in what is the status quo. And so they've modeled this out. And I think it's really quite apropos of what's happening right now in the world, right? Creativity, I think, is really at the forefront. The truth is, we don't know what the world is going to be like in the next 25 years or so, except it's going to be very different from today. And I think because of that, we have to be thinking about what's new. At our own university, we have a new university president at McMaster University. And, McMaster has historically, been a very research-intensive university in Canada, so much so that, it was the founding institution of evidence-based medicine with some of the pioneers still there, a big part, along with Harvard, as being the problem-based learning for their medical school. But they've actually said, those days are gone. Like, we have to re-innovate. We have to come up with new traditions. We have to come up with new areas, and we have to lead through, and she has said, bold creativity, innovation, and impact. So I think from that perspective, I think it's fundamentally interesting and important that we think about it. The other thing I would say also is that we don't want to confuse being productive with being impactful. Something I used to always think, well, I thought, like writing and publishing, and I don't know at this point, but I suspect I'm somewhere north of about 1,100 peer-reviewed publications. And while that may seem very, impressive, actually, I look back in my life and I think, the truth of the matter is a lot of this was probably like the impact I had was probably based on about maybe 15 to 16 papers. And if these 15 or 16 papers were my resume, I'd be extremely proud. Now, that doesn't mean that all the other work was completely wasted, but I've actually added the number of hours I've spent writing the additional 1,000 or so papers, and it's about 10 actual years of time. And I wonder what a decade of my life back could have done. We have spent a lot of time doing trials, large randomized clinical trials, and probably randomized somewhere between 80 to 90,000 patients. I believe that has led some degree of impact. But I'll even go further. I'm not even sure this leads to the impact that I'm talking about. And I think it's been shown. There's been paper after paper that talks about that the individual productivity of a scientist and the average impact per paper of that scientist are almost uncorrelated. And if you look at what's happening with publications and patents around the world, lots of them. This is published in Nature. You see like a decline everywhere. So what's happening? Papers are becoming less disruptive over time. And that's a real challenge. And one might argue, at least one of the hypotheses could be, well, maybe we're just not coming up with good ideas. Because even if you have a beautiful study design for a relatively uninteresting idea, it's not going to lead to an impactful outcome. So innovation is going to be informed by our creativity, and creativity is going to be linked to our ideas. So today I'm really focusing with you, a group, interested in research, a group interested in ideas about how to really think about that. We can have lots of ideas, and that's great, but if you never act on the good stuff, you're imaginative, right? You're not creative. And here's the point, right? Just being creative alone in an echo chamber is not going to be enough. You actually have to have domain expertise. And in fact, if you look at Nobel laureates and the more recent ones, they often tell you, well, what they did is they took domain expertise in two very different areas, and they brought them together in a new and creative way. So I do think it's really, really important. Creativity has two requisites. And this is a paper we published recently from our team at McMaster in the Creativity Research Journal, which was our at least working model of what we think creativity in surgery is. The generation of a novel and/or useful products, ideas, and solutions to unsolved surgical problems or problems that others have solved differently. Two things, right? The idea is to be novel And ultimately, to be creative, it actually has to have some use case, right? Innovation requires a use case and usefulness. And so while intelligence has been going way up, we've noticed that creative thinking has been on a decline. You can give the same test to an adult and a child. The child will ace it, and the adult will fail it. Why? Well, creativity requires having lots of ideas, having different types of ideas, having ideas that are quite original and unique, and really fundamentally important. And why I believe it's such an important thing to have a strong network is remote associations, taking ideas from two disparate areas that may not normally collide and colliding them together. And there's ways in which we can certainly do that. We actually did a paper on this. We actually looked at 80 of our trainees, whether they're medical students, first and second year residents, all the way up to senior residents, and did standard tests of divergent thinking or creativity. And here's what we found. Functionally, you can see as you get higher on in your training, your creativity scores go down and they get further and further down. In fact, what was most startling was our residents' ability to generate original ideas was significantly below average. So that was a bit of a startling finding, but it may be quite reasonable, right? To think that, well, you don't want surgeons to be particularly creative per se in the operating room. You want them to have had an apprenticeship, just like pilots, to know that there's a checklist that you're going to follow and you're going to do it at a level of expertise. But arguably, the idea still is the critical first step in innovation. And more recently, right, last year, we saw the Nobel Prize in Physics given to Geoffrey Hinton and John Hopfield for discoveries and the inventions that enable machine learning, artificial neural networks, and basically AI. This was 42 years ago. Their seminal paper was April of 1982, 42 years ago. And the only thing I think, and certainly it's become very apparent that why this didn't move any faster is because they didn't have the processing power. And you realize now that everybody, all the big companies, spend all their time looking for more processing power. And AI is a race for getting power to be able to run the algorithms. But now that you have this power, look what's happening with respect to its use. We're seeing it being used now in drug discovery. McMaster's gone all in on this at our university. What used to take, decades to complete and multiple billions of dollars is being done really quickly. We've actually seen now published AI discovered drug successes in phase 2 studies. So they developed a drug through AI and were able to predict that its function, and then now have actually shown in a phase 2 trial that it is actually working the way they thought it would work. That's a 50% reduction in time and a really major reduction in cost. So AI is not going to take your job, as everyone says, and Jensen Huang keeps telling everyone it's not going to take your job. People using AI will take your job. But here's the point too. With everybody using AI, there's a new term that's come up, and Harvard Business Review had talked about this recently in their September issue. Says there's this thing called AI work slop. AI generated work content that masquerades as good work, but lacks substance to meaningfully advance a given task. In fact, they're saying that they're often creating low effort, passable looking work that ends up creating more work for coworkers. And so they're creating this new world. So yes, it has lots of power, but it may also have some detractions and things that we're going to have to think about as we move forward. But who is the best creative partner? Well, research still tells us that individuals, humans working with another human, at least in the present day, still outperform students or individuals working with the internet alone or students working with AI. So for now, why don't we make the argument that AI is reasonable? It knows everything from the past, but great breakthroughs have often come from people that were unreasonable. So I think there's a real play here still for humans. Let's agree for now anyway, that humans remain the creative engine. So if that's the case for you individually and you as part of the team, here's things that I've actually done for myself that I found to be very, very helpful. I've made a very concerted strategy to do less in my life, to slow down, absolutely slow down. Now, we were forced, all of us, to slow down in 2020, but I think now that things have sped up again, it's not bad once in a while to slow down again and really think, okay, is it quantity? Am I really out for producing stuff, or am I looking at quality outputs? And I think when you do that, that's very helpful. So these are the steps that I've taken in my own life, and I'll share a few of them with you. The first thing is I've created time. I used to never think that time was a possibility to just, quote, do nothing. I don't know how many of you schedule time to, and I won't say do nothing, because doing nothing is actually doing something, but blocking time away in your day that's protected for you to reflect on a problem, to think about a problem. It's very easy, and I'm sure you see this, that it's very easy to show people who are highly successful and say, look at how much they think. But the truth of the matter is, even for individuals like us, just looking at qualitative reviews that we've recently done, you don't need a lot of time to yourself every day to come up with some interesting insights. Think about a problem, but say, I'm going to take some time. I'm going to take 10 minutes today, and I'm going to just think about this one problem, not to let myself daydream too much, but really focus on a problem. But here's the challenge we all face, and I'm sure it's happening at your institution as it's happening at ours. If you show the incentive, you'll know the outcome. Are we incentivized in academics to think? It seems like the most logical thing you should be doing, but it's rarely, if ever, quantified. Because when you spend time thinking, it's perceived that you're not producing. Now, we're not producing, we're not publishing. We're not producing, we're not getting grants. We're not producing, we don't have patents. We're not producing, we're not creating companies. I get all that, right? And if you're in surgery, you're not producing if you're not generating revenue from the point of view of treating patients. So from the hospital's point of view, let's say. But from your personal point of view, it's about how am I going to get to the absolute best version of being able to come up with the stuff that I think I need to do. And we need an incubation period. Nobody, and I have spoken to probably tens of thousands of people in the last 7 years around this issue of when do you get your best ideas? Nobody says I get them at work. They get them everywhere else because they need this period to incubate, because that's really where the magic happens, right? It's that place where, when you're away, your mind is still thinking about that task, right? And there's actually a psychological effect that describes that, right? We remember the unfinished task better than the completed task. So when we're working on something, no matter if we leave to get a coffee, go for a run, do something else, go for a hike, whatever it is, you're remembering that task and you're thinking about it. So the first thing is you got to get time. You got time to think. And when you actually do take time and when you're in your day-to-day life, I try to be more present. I used to focus so much on what's happening tomorrow or worry about what just happened last year or last week or yesterday that I used to completely walk through the day somewhat like a zombie, just trying to get through my day, not thinking about being present. But we are missing the majority of the stuff that's happening around us. Look at this individual. He is by far the best climber in the world. And when he's asked about, well, why do you climb? He says, well, I climb for the sake of climbing. I'm in the moment. That idea of being in the moment seems so trivial, but it's absolutely so fundamentally important. You can't go to a concert anymore and look at the concert. I'm of the age, friends, where I used to be able to go to concert and those would be actual lighters. They were not cell phones. We were functionally all together having a community experience. Now when someone says, well, how many people attended that concert? Say, I don't know how many people, but there were at least 15,000 iPhones in attendance. That's a very different world we're in. We're looking through a camera to capture something that's happening right in front of us rather than just experience it. One of my absolute favorite storytellers, Anthony Bourdain, said, master details in the ordinary, as though you're seeing them for the first time. How do you look at your own data set? How do you look at your own team and the way the things you're doing with a sense of wonder rather than, I just got to get through this data set. I got to get this analysis done, whatever it is, right? It's training yourself to think differently. And we are trying to do that. So we've tried this. We've created these programs at our institution where I'll take our graduate students, a small group of them, and we'll put them in a place that they've always been, give them a camera and say, now you've been here lots. Go take a photograph of something you've seen and really notice something. They'll come back, they'll show something, and then there'll be multiple different perspectives on the same thing that person saw with a different interpretation. I said, now imagine if you did this with the work, your daily work life. Imagine you did this with your next grant or your next publication, whatever it is. The other thing I think it's really important is to let chance happen and almost create a little bit of chance, but know that you have the wisdom to know that could be a really good opportunity. We've been doing this for a long time. It's called breakfast breakthroughs. Simple thing, that the rules that we have are identify 2 or 3 people that you've never met at your institution and send them an email, invite them to a breakfast, pay for it with no agenda, and just see what happens, right? So when you bring people very different than yourself, it gets to the idea of connecting remote associations, getting experts in fields that are very different than yours that you probably wouldn't ever really run into. But when you do run into them, you realize that there's some really interesting commonalities between an economics professor, a nursing dean, and a music professor who's sitting on one behind me, and we're all chatting away. And we had not met each other prior to this. This is about 15 minutes into it, and you realize how quickly we're connected. So I would urge you to think about that. The last of the two here is don't just focus on your network. Focus on a high value network. And what does that mean? It means invest in the absolute best people you can find around you. The thing that's amazing about productive, impactful scientists, they have a real strong preference for collaborating with guess who? High impact, productive scientists. So if you can identify people in your institution who have the same curiosity and keenness for a problem, even if it's different than yours, it could lead to some really interesting opportunities. In fact, we always say at McMaster, don't settle for the person in front of you. Find the best person in the world. The great thing about being at your institution, Harvard, is you have so much resource of intellectual capital that you're pretty well the envy of most institutions. So take that opportunity and I would say go with it. This is Professor Gordon Guy. For those of you who understand the H index, his H index is 304. He's in the top 1% of all healthcare scientists in the world. And that circle in the middle there that you see the little graphic here, that's him. But look at all the other circles around him. He has created probably hundreds of high impact scientists just because of their part of his network. And I think it's really important that as an early career researcher or a senior, our job is to help you find those networks, or your job is to think, okay, where are these networks and how do I work within them? How do I collaborate within them and move? The thing you'll learn, and I've been fascinated by in studying prior Nobel laureates, is most of them have actually had 3 to 5 completely different areas of research. And here comes that word again, remote association. They're developing expertise in different silos in hopes that sometimes you can actually have bridges that could be novel, new ways of thinking about a particular problem. So that's really interesting. And finally, I'm going to end this, and I'm giving you a bit of a précis, so this would be much longer normally, but I want to be respectful of your day and your time. But do something for you, like really do something for you. When you create something truly for yourself, you're doing the absolute best thing you can for, we'll say, quote, your audience, but the people around you, right? Your network. I took this pledge in 2018 and I absolutely live by it. I try new things. I look at every week and I say, this week, did I try something new? Did I do something that really got me thinking about creativity and harnessing it? Did I stay true to the 20% of the things that give me 80% of my real joy and purpose in my day, my work, my life? Did I take some risks? And did I say no to at least a couple of things? We all get lots of things, but saying no is empowering because then it protects some of the other things you care about. And then did I actually stay true to myself? And was I generally, in my mind, being kind to others? But being kind to others means you got to be kind to yourself too, right? And make sure that you protect the things that give you value. And one of the things that gives you real value, I think, and successful scientists have figured this out, that you need to have hobbies. Hobbies that are going to allow you to, get away, to incubate, to whatever that is, right? To come back on the problems that make you better at your work. These don't make you less productive. I actually think they make you more impactful because you can bring that time back and actually get the ideas that really matter rather than lots and lots and lots of ideas that you're just publishing every day. Listen, we all have things we used to do. I used to blank, but for some reason I gave it up. You can fill in that blank for yourself. And I would ask you to reflect on why you gave it up, and whether it wouldn't be a bad idea to think about reinvesting just a little more time into that. And again, it's not rocket science, folks. It's just you need sleep. It's nice to have something to do outside of your job. Getting outside of your office is really important, and connecting with people, especially outside of your office, is fundamentally important. So, folks, I always look at this, and I take sort of a stock of where I am every year. Okay, everything I want to do in the future is opportunity. Everything I haven't done yet is still a bit of regret. Maybe I should do it this year. And the only thing that's stopping me is this perception that I have time. For me, at my stage of my life, it's age. I don't need an alarm clock. I don't need any other bullet points. I just know that every day I don't do something is an opportunity missed. So I'm trying everything and moving forward. Listen, 1 in 10 of us is going to think about doing stuff. 1 in 100 will probably do it. And then it's that rare group, I suspect you're part of that rare group, that just keep at a problem and keep working. And that leads to your ultimate fundamental success. Most of us say, We overestimate what we're going to accomplish next year. We have all kinds of dreams, but we grossly also underestimate what we're going to accomplish in 10 years. So I urge you to continue at it. And when you do take that first step, doors open, right? People open, doors open, and things really, really work in your favor. So if you do one thing from hearing this today, I would just ask you to make yourself a small little contract. I, so-and-so, am going to commit to 1 hour per week of time and make that time fundamentally important for you, whatever you want to spend that time on, but make good use of it. I promise you that if you do that, you'll look back in a month, 2 months, and you'll say, I can't believe I haven't been doing this all along. And if you're already doing it, you might add another hour, right? And I've never looked back. Now, I may be wrong on all this. I may be wrong. But you may look back someday and say, maybe he was right. And maybe that is a way to think about going forward. We talk to all these folks much further along in their life. They have the same message. And so I wish my younger self had had this message much earlier than I got it. Because I think it would have made a huge difference. Because it would have let me make the idea of being creative more a habit rather than a hope. So thank you very much, folks. And again, I really apologize for some of the delays in getting to you today. But anyways, thanks so much for giving me a chance to chat with you.
Dr. Bhandari, thank you. Great talk. You touched on it at the very end in terms of the fact that, what you would tell your younger self. So we have a lot of young orthopedic surgeons, a lot of young researchers. And can you specifically address, so there's a lot of pressure to publish volume, right? Whether it may not be impactful, it may not be well cited, but of course that is tied to podiums and grants and academic promotion. And so how would you tell a young researcher or surgeon to balance that?
Yeah. So this is the hypocrisy that's going to come up now, John. You're going to see, so the first thing someone says is, well, you can go ahead and tell people not to publish. You have 1,000 papers. You've gone through all that process. And I understand sort of the reality of what I'm telling you, but I would say the following. I would say early in my career, what I don't regret is walking through every door that was open for me. And many of the students here are looking to all of you as the senior faculty and helping them move forward. I think that's huge. I think walk through those doors. But there's a point at which, once you've written 2, 3, 4, 5, 6, 7, 10, whatever that number is, there's a point where you get to diminishing returns on just being on that treadmill. And I would then and part of it is that for a student, you want to always be open to ideas, and I think it's good. But at a point, you want to definitely take a step back much earlier than I did. I think I probably should have taken a step back, and forget about numbers of papers because that's irrelevant, right? I mean, but like much earlier in my career to say, okay, maybe I should say no. But the fear of saying no, John, and this is, oh gosh, if I say no to my profs, that they're never gonna ask me to do it again, because the person who gets the most work is the person that continues to accept the most work and continues to, plug away, versus the person that's much more discerning is often seen as, they're not really committed, they're not interested, they're not this. I would tell you that in my experience that I've recently, I'll tell you, I have two graduate students with me, very different phenotypes. One is an individual who is, much more, I won't say thoughtful because they're both extremely thoughtful. One has probably 30 papers a year, he writes, very busy, super intelligent, super motivated. And the other person might write 1 or 2. And yet, here's the funny thing. The person who writes 1 or 2 is so envious of the person that writes 30. Let me keep it quiet. The person who writes 1 and 2 is publishing in the top medical journals like JAMA. He's had 2 JAMA papers in a year, which is pretty impressive for a healthcare researcher. And the other fellow who's had lots of papers, but they're in more subspecialty areas and they're smaller impact papers. They both crave the other person. Like they crave what the other person has. The person who has 2 says, I don't think I'm productive enough. And the person who has 30 says, I wish I had that. And I think that's our life. I think that's what we end up doing. So I would say is if you're writing a lot, you almost want to interact with someone who's writing 1 or 2 major impact papers and understand why they do that. And the person who's writing the 1 or 2 and wants to see someone who's very productive, you learn skills from each other. I didn't have that. I just, I was just trying to plod away. But I was in a group of people that were very, very outside of surgery, that they were just very prolific individuals. Gordon Guyatt, for example, was one of the people I was in the group with, but everyone in that group were extremely high achieving. So you always felt like you're underachieving. And maybe that was my own insecurity about having to write as a way to feel like should be part of that network.
John, may I ask a question? Yeah.
Please.
Dr. Bhandari, yeah, thanks so much. This is great. I wanted to hop in because I'm struck by listening to your talk and looking at your photos that you put in there with your connection with people, and those are photos of people in person, and you're mountain biking with people, and you have this interpersonal connection. It feels like that builds collaboration in person. So I'm interested in your thoughts on this format and how to think about how things have changed in terms of connection, given that we have all these Zoom formats and Teams meetings that kind of work and kind of don't. But how do you think about collaboration now in terms of its impact on creativity, given that we have the opportunity to have meetings like this where we're not together, but there's obviously a drawback to that. So how do you put that together in terms of thinking about this?
Yeah, and I don't know, but truly, Jeremy, like what are my insights on this are going to be any more valid than anybody else's. But I'll tell you the thing that I do find. I find having large meetings like this very valuable in that you can share, information, you can share ideas broadly. But I think if you're going to deeply get into innovation and creative thinking, I think it's very hard to do remotely. And I think this would be an opportunity to say, okay, what's happening in the group? And then develop a network and say, okay, now you and I, or this small group needs to meet and do something, or we need to connect with someone and do something. So I see the value of just major meetings, right? Going to a meeting. But I would gather that almost all of you would have had the experience where you'll go to a meeting, you'll listen to the lectures, but the real magic of the meeting is happening at all the breaks where you're one to one, you're sitting in a corner, you'll randomly walk by someone and you get introduced to somebody else. And that leads to something really interesting. So the idea of, going to a meeting or having serendipity or trying to, like we're trying to create this idea of meet new people, different than yourselves, that are also like you though, right? They're like you, but they're just in a different field. That's where I think really interesting things can happen. We get caught up in our own silos, even our own institution, and people say, I don't have any new ideas. We keep doing the same thing, or and you just keep rehashing the same idea because we're not thinking differently, because that's all we know. And so we've been really trying to get out of that. So Zoom is great for that. To answer your question, I think Zoom is good for broad, communication. But I think if you really want to have impact, we got to get in front of each other and get off Zoom.
I want to be respectful of Dr. Bhandari's time and actually everyone on this call. Do we have one more question from the audience?
Hey, John, I have a quick question.
Yeah, go, Chris.
Hey, Mo, as you've gone through this period of personal realization and growth and epiphany, can you talk about your thoughts and specific strategies for this, the phone? What do you do with it? Do you leave it behind? You go for that walk? Where is it? Is it with you all the time?
The problem is I love taking photographs. So the phone's always with me. Like that's the problem. But I do think I've been really trying to be like, for example, Gordon Guyatt, that was like that picture I took with him on the bike was 2 weeks ago, and we're booked for next Monday from now to ride again. And we ride because we ride because we enjoy being out there. But when you ride, what happens is Gordon Guyatt's a giant. I'm not that. But suddenly, when both of us are in nature, we both feel pretty small. And you're looking up and you're in awe, and you've got all the other things that are happening. We start behaving like humans. He'll tell me things that I'm asking myself, why is he saying this to me? And I realize because he doesn't see me as a student or as a mentee. We're just two humans interacting. And it's because of that anything I say has much greater value to him because he's looking at me in a different way and I'm looking at him in a different way. Anyways, I would say to you that getting out with people and doing something, the phone becomes less interesting to you. It's only interesting when you're in a big meeting and you're just trying to, be hyper productive. So if I give you anything, I genuinely mean it. Give yourself, if you're not doing it, 20 minutes next week, I'm going to do something for myself. Or the next meeting I have, I'm going to go on a walk with somebody. And it may seem crazy to you in the beginning, but you'll never stop once you start doing it.
Hey, Chris, in my house, we have a little box. So when everyone gets home, the phones go in the box. Sometimes it works, sometimes it doesn't. Maybe that's why I'm missing your text at night.
Hey, that's
So,
pretty good. That's worthy of a clap there, John. That's pretty impressive.
Amen.
All right. Well, Mo, thank you so much for joining us. And hey, Jeremy, why don't I turn it over to you to introduce the next session?
Great.
Right. And thank you all. And I apologize for the delay. I know I've kept you a bit behind. So thanks a lot. Really appreciate it.
Thank you.
Thank you,
Cheers.
Dr. Bhandari.
Bye-bye.
Great. All right. Well, thanks, John. And okay, I'm excited to introduce our moderators for our next session, which is on ankle fracture treatment. So we have Siddhartha Sharma and Nicholas Yee. And so I'll turn it over to you two, and please take it away.
Nick?
Thank you so much, Dr. Smith, for introducing the next session. Congratulations to the team. We're going to build off the amazing steam that Dr. Bhandari has led us on. It's a pleasure to be a moderator with my co-host here, Dr. Sharma, on the next session on ankle fracture treatment. We have three amazing speakers coming up: Dr. Chris Miller, Dr. Amgad Halim, and Dr. Jeremy Smith. We just heard. We'll do 3 10-minute presentations, and we'll leave the discussion at the end. And so without further ado, I would like to start with Dr. Chris Miller. He's a professor from the Brigham and Women's Hospital. He's renowned internationally for his MS procedure. So looking forward to his talk.
Hey, how do I advance this? Can I share my screen instead?
Atta? Yep. The slides or your keyboard?
Not doing it. Oh wait. Controlling. Can you unshare and then I'll share mine?
Sure, yeah.
Okay. Thank you. Appreciate the opportunity to talk. So, and I especially appreciate the opportunity to talk after Dr. Bhandari. Thank you. I'm sure my talk will be even better. But what I hope to do is leave you maybe with more questions at the end than answers. And as I was putting this together, I kind of had this thought that, I want to talk about why are we not doing this? Why are we doing it? Should we be doing it? And, what can we do with an arthroscopy set up in the setting of ankle fractures? And maybe we'll see where we end up here. Okay, so these are my disclosures. So I'm not going to belabor ankle fractures. We are all very familiar with the various types, many different classifications. And, we know that outcomes will base, at least in part, on the severity and the complexity of the fracture. So, we look at all these different things, which are just pulled from the web, but, some of these we just know on some level are going to do worse than others. And I think that's borne out in a bunch of the literature. And we're familiar with AO principles. We want to get our length, rotation, alignment, rigid fixation, early mobilization, early weight bearing maybe. I think these are all things that from an orthopedic stuff we have control over, and we can try to get people's outcomes better, right? And that's what we're trying to do, and that's what we want to think about doing. And I think when we think, and certainly when non-foot and ankle surgeons think about ankle fractures, they do great. And in general, they do pretty well, but there's this group of, 10 to 20% of people who, are not doing as well as we would like to see them long term. And also we know more complex fractures have higher rates of osteoarthritis down the line. Is the syndesmosis injured? How many malleoli? And so there are things that we cannot control, but things that we still want to try and do better with. And at the same time, we can't control the injury pattern. We also can't control what happens at the time of injury intra-articular. And a lot of studies have come out over the years here saying that, 50% of osteochondral lesions, almost 80% more may have some associated occult intra-articular pathology. And this is sort of the first evolution of arthroscopy where, we can look and we can see. Okay. And, so as I was going through this, I was like, well, why are we not doing this more often? And, what I see as a foot and ankle surgeon is a lot of these might be fixed by our non-foot and ankle colleagues or trauma surgeons. They're going to get them through the acute phase of care. They're healing. They're doing great. They're going to go, that's the expectation, but if it's still painful, they're going to get sent to one of us, and then we have to figure out why they're having pain. And so what's going on with this 10 to 20% of patients? Is there anything that we can do to try to improve on that? And so, arthroscopy is, something that we like doing across the board in orthopedics, but then for ankle arthroscopy, it's a relatively rare skill. Not a lot of surgeons have this. Now we do it all the time, so we think it's something that's pretty easy, but they don't have the setup. They maybe I was just at the Brigham yesterday. If we tried to do our arthroscopy at the Brigham, it would like melt down. So our trauma colleagues aren't doing it. Time in the OR available equipment. This was a review looking at a big survey, and only 1% of ankle fractures actually had a concomitant arthroscopy at the same time. So, as foot and ankle surgeons, the few, the proud, this is definitely our wheelhouse. And I think we find scoping to be pretty easy, and nothing's easier than scoping an unstable ankle fracture because you can just distract the whole thing very easily. So, for me and for most of us, this is not going to add a lot of OR time, and we can see more. But so at the same time, we have this tool, we want to use it, but should we use it? And in the immortal words of Ian Malcolm here from first Jurassic Park, should we do it? And I think that's the question. So looking at this, we know there's a high rate of intra-articular pathology. We can find it with this, right? So why should we scope? One, it can be diagnostic. We can find this stuff. We can maybe help predict long-term outcomes. Can we treat the occult findings? This is sort of the next layer. So do we debride, remove the loose bodies, treat osteochondral lesions, flip the medial ligament out of the way if it's blocking reduction? But I would argue that's sort of like that's the intro level stuff. Can we do more? What else could we do? And even just with this, when we look at outcomes, and there's been some recent studies looking at this, and keep in mind, these are all done by people. I mean, Ken Hunt is a master of arthroscopy. So, this only added 10 minutes to his surgical time. He had, 30% osteochondral lesions, 33% loose bodies, 50% partial thickness cartilage injuries. And when he looked at it, he showed some improvement with PROMIS scores. Is it, a 3-point increase? It's statistically significant. Is it clinically significant? You can argue. Patients were more satisfied. And when there was an associated dislocation, they had a higher degree of increase and no increase in complications. This is another one, and they tried to match the two patients who had arthroscopy with ORF to patients who just had ORF, and they tried to match it based on propensity scores. And they showed that the patients with arthroscopic assisted ORF had better outcomes at 4 years. This is the graph just showing increase in the FAM, ADL, and sports and OMAS compared to ORF alone. So perhaps we're getting some improvement on that 20%. Two recent meta-analysis sort of showed the same here. So favors here, this was outcomes, and then this was, I believe, complications here, or VAS was down below, and this was complications. So slight improvement relative to the arthroscopic assisted. And then the same one, same findings here. This was looking at some randomized control trials and showed improvement in functional outcomes following arthroscopic assisted compared to ORF alone. Okay, so, we can do it. I think these studies say that there may be some benefit for it if you have the skill set. And if you look at the history of arthroscopy, I'd say it starts with a phase one, like, hey, I have a new fun tool. This seems cool. Let's see what happens when I use it. And that's where we can find the pathology. But then you open and do it anyway. So I would argue this is what we're doing mostly with the ankle fractures. Phase 2 is I found stuff, maybe I can treat some of it, but then I can open do the real surgery. So, scope perineal brostroms, things like that. And then phase 3 is let's see how much I can do through the scope. And this is where, our sports colleagues are with their ACLs and rotator cuffs. And so I like trying to find ways to drive down this list here. We talked about syndesmosis. I'm just going to show, we know we can look at this. We can see if it's stable or not. We can see the drive-through sign nicely. I think Daniel showed some of these before. And we can test if it's unstable. We can repair it. I can put a tightrope in. We can take a look. And even after that, we can see how stable it is after we've repaired it. But sometimes, even after repairing it, we still have the sagittal plane malalignment. And so this was a further case of mine here where I then reconstructed the AITFL anteriorly with a sort of internal brace type construct, putting that in and locking us in place. So not a complete ankle fracture, but an example of doing something more and trying to move down that list and actually treating the pathology that we're seeing interarticularly as well. So, where are we now? I think, we're sort of in this phase 2 of this artificial phases I've given. We can treat osteochondral lesions, we can remove loose bodies, and there's evidence saying that may improve our outcomes at 3 and 4 years. Can we repair? Can we do the deltoid? Can we do lateral ligament repairs or fibular nailing? I'm obviously like MIS and arthroscopic treatments. Like, what else can we do that may improve outcomes? And I'd say this is more the arthroscopy phase 3 that I would love to see us get to at some point in the right patients and the right pathology. So sort of wrapping up, this is possible. I do like doing it. I think the biggest challenges are, availability of the implant. It does require a little bit more time, but it may require more time to set up, turn over the room, get things set up with your staff, which is a big concern for me, especially in some of our systems here where the turnover can already take a little bit long time. And then familiarity, like our trauma guys are never going to do this. So I think we're at phase 2 here, and I would love to see this group talk and think about doing stuff beyond and doing more arthroscopically so that we can maybe improve our outcomes even better. So we have the skills, and hopefully FARIL can continue driving the discussion here. Little plug for our Foot and Ankle Journal Club next Thursday. Thank you.
Thank you, Dr. Miller, for that excellent talk on arthroscopy. I'm sure people have questions. And guys, if you have questions, put them up in the chat box. We have questions at the end of the session. And next up, it's my great privilege to introduce to you Dr. Amgad Halim. He is an expert, world-renowned foot and ankle and deformity correction surgeon. He's also the director of limb lengthening and deformity correction program at Mass General Harvard. Over to you, Dr. Halim.
Thank you so much for the introduction. And it's always very difficult to follow. I'm going to try and show some nice cases for you and an algorithm. We're also going to be very mindful of time. So I know we're running a little bit behind, so I'll try and stay on time for that. I'm not going to talk about the anatomy. We all know it. The deltoid ligament has 2 components, the superficial and the deep components. The superficial component resists valgus stress, and the deep component is the one responsible for the external rotation stress. I want to emphasize that the deltoid, not only being delta in shape, this is the superficial component, but it's also continuous with the spring ligament or the calcaneonavicular ligament involved in flat feet. And that has repercussions in management of chronic valgus instability and deltoid deficiency. And the deep ligament, as we can see, has 2 limbs mostly attached to the talus. A little bit of mechanics, just like with the ATFL and CFL, in plantar flexion, the anterior portion of the deltoid is tight, and with dorsiflexion, the posterior portion is tight, and that helps us, again, understanding the restraints in repairing that. Now, we know the pathoanatomy. This is, the supination, external rotation injury. And in bimalleolar equivalent ankle fracture, the injury starts at the syndesmosis and then goes all the way through the back and ends on the medial side. So if it doesn't break the medial mallet, it's going to disrupt the deltoid. And the first component that's going to be disrupted is not the superficial deltoid, it's going to be the deep deltoid. And then it's going to be the superficial deltoid. That's why we use the external rotation stress tests, because the deep deltoid gets disrupted first, and then the superficial gets disrupted, resulting in the valgus stress. We all know the classifications, grade 1, 2, and 3, partial tears, incomplete, and complete tears. And then Hinterman came up with a nice classification where he also divided the deltoid into proximal tears or avulsion from the medial malleolar side. And this was found to be the most common pattern with 72%, followed by an intermediate deep component remains attached distally, while the superficial component remains attached proximally, so it's vice versa. This is only 9% and the least common. And then the distal tear on the talar and the tibionavicular side or the spring ligament side is the second common with 19. So I want you to think proximal and then distal and then intermediate or in the mid substance. Diagnosis. Deltoid diagnosis in the acute setting is easy. You want to feel tenderness and hematoma formation along the medial side. So tenderness on the medial side and absence of an ankle or a medial malleolar fracture. We all know the external rotation stress test. So this was after fixing the syndesmosis and externally rotating, and there's still winding that indicates disruption of the deep deltoid. And then you follow that with a valgus stress test and look at the valgus or the talar tilt. And that's indication also of a superficial deltoid disruption. Now, this is where it gets a little bit finicky and we don't delve into it a lot, but in the chronic setting, a chronic deltoid deficiency can happen. And it's usually augmented by the fact that most of these patients are going to have a pes plana valgus or progressive collapsing foot deformity or a posterior tibial tendon dysfunction. And that increases the medial laxity and gives room for the modalities we've mentioned before. We've talked about the weight-bearing CT. I'm not going to delve in that for the sake of time. And the MRI, which we usually do not get in the acute setting just because of their easy diagnosis. Now, down to the beef of my talk. The repair versus reconstruction. So repair, we have the open technique and the arthroscopic, not the endoscopic. But this is a nice summary out of a JAS, a paper looking at the different techniques in repairing this. So basically, you either repair it from the proximal end with suture anchors or on the distal end. So I'll share with you that paper. But there are many ways of repairing it according to the pathology I mentioned before with the Hinterman classification. You want to be mindful, is it the deep deltoid that is torn or is it the superficial? And I always tell my fellows and the residents, if you're only going to repair the deep deltoid and you go through a medial approach, you're not going to be able to see the deep deltoid torn in isolation. So the classic approach is to do an anteromedial approach so that you can see the deep deltoid fibers and be able to repair them either proximally or distally. And then through that approach, you can also see the superficial. But if you do the traditional medial approach and there's an isolated deep deltoid ligament tear, you will not see that, you will not see or be able to repair the deep deltoid because the intact superficial deltoid is going to be in your face. This is the yellow journal paper I talked about. It was published in 2019 by Simon Lee and the group in Chicago. It gives a nice layout of how to repair it, and these are the the proximal repairs in the medial malleolus, the suture anchors, and this is for both the superficial and deep deltoid when it gets disrupted. Dr. Juarez gave an excellent talk, and so did Dr. Miller, about the arthroscopic repair, and it's super easy to identify the deep deltoid being torn and shredded from the medial malleolus. And again, it adds 10 minutes. If you're doing a deltoid ligament repair, then it's going to be a little bit more time, but it's not super difficult. And it's very easy to diagnose with an ankyloscope, just like Chris mentioned, with a valgus stress test, and you can see the disrupted the disrupted end of the ligament with possible osteochondral lesions on the medial side that can be attended to. So now we talk about reconstruction. There's internal brace augmentation, and then there's spring or deltoid and spring ligament augmentation in chronic cases. So usually, if you open the ankle, which is very, very rare, and you're going to find a completely deficient deltoid, which is, again, going to happen more in the chronic setting rather than the acute setting, then there have been multiple techniques described for reconstructing the deltoid. This was a technique published by Fulvesson using Achilles tendon allograft. The peroneal longus, a posterior tibial tendon autograft, or a semi-T allograft have all been described by Jonathan Deland out of special surgery. But I think now the most common one is the technique described by Pioneer with the internal brace, or what we call the bio brace, whatever type of braces we're using, where you're actually recreating the delta configuration of the deltoid ligament with anchorage into the medial malleolus, and then in the sustentaculum tali, and then the talus and the navicular. Now, this is what it looks like. Again, this is the medial malleolus. You would have a ligament, one limb going all the way into the sustentaculum, and then the other limb going into the talar neck, and that stabilizes the ankle. We're going to be talking about chronic deficiency right now, and how to reconstruct the spring ligament in addition. Now, this is again a internal brace repair of the deep deltoid, where you've had one limb of the internal brace in the medial malleolus and the other one in the talus right there, and then you tighten it at the appropriate tension. Now, when do we talk about spring ligament augmentation? As I said before, the spring ligament has been found to be a continuation of the deltoid ligament, and that forms what's called the tibio-calcaneo-navicular ligament complex, but this all becomes a single complex. And to do this, the most common, again, use is with the bibrace or the interbrace technique, where you're putting your construct here in the medial malleolus and then doing the usual spring ligament construct, but instead of looping it over and back on itself for an isolated spring, you take that limb and you take it back again to the medial malleolus. So you've got one limb of the brace going here, and then going through in the sustentaculum, coming out at the navicular, and then reattaching it back again into the medial malleolus. So when do we do a spring ligament augmentation? Usually it's again in chronic insufficiency with impending or early flexible ankle valgus, but also prophylactically in patients with impending or early flexible hindfoot valgus, because you want to avoid seeing that foot gliding into valgus gradually and opening out that medial deltoid or the medial clear space. And this is a video that I think I'm going to skip for the sake of time, but it's very showing of the technique, and you can find it online, so we're going to skip that. When we talk about the results, this is a paper we published back in 2019, very early, where we tried to do a meta-analysis, looking at the literature and whether there's justification to fix the deltoid or not. And I will tell you, this was based, if you look at the literature, there's a classic JBJS article with a randomized controlled trial that showed there was no difference at 3 months and 6 months with and without repair of the deltoid. But unfortunately, this was out of a trauma institute where they weren't emphasizing medial instability, long-term follow-up for deltoid insufficiency and valgus formation. So when we look at this meta-analysis, again, the current literature at the time, back in 2019, did not provide clear indications for the repair of the deltoid. However, we thought there might be some advantages. Fast forward in 2021, this looked at comparison of deltoid ligament repair and non-repair in acute ankle fracture with another meta-analysis. And it seemed to find a little bit of a difference with advantages with deltoid repair in terms of post-operative medial clear space maintenance, improvement in AOFAS scores, and decreased rate of complications with the deltoid repair. In the acute setting, the deltoid injury often coincides with multiligamentous injury. So another study looked at in the acute phase, repair remains a subject of debate, as I said before. But in chronic deficiency, there is definitely a role in the hindfoot valgus with a combined deltoid and spring ligament reconstruction. This is a study that came last year, and it was KSSTA. There is limited evidence available regarding deltoid ligament injuries, particularly in terms of treatment options, either in isolation or with concomitant injuries, but long-term follow-up studies are needed, and that's what we are pursuing right now in our institution. So in conclusion, deltoid repair is indicated in the acute setting with complete tears of either component, and that can be detected clinically and radiologically. The arthroscopic repair is an emerging technique with good results. Steep learning curve, time-consuming. Chris Miller can argue against that. The reconstruction in the chronic deficiency setting is required, and our options are autograft, allografts, and internal brace. The fiber tape augmentation or the BioBrace may be currently the most popular one due to the limited donor site morbidity and decreased associated infections with allograft. And be mindful of the deltoid and spring ligament reconstruction, in addition to any bony realignment procedure required, especially medializing calcaneal osteotomy, and the flexible ankle valgus and the flexible flat foot. Thank you.
I'm going to go ahead and share my talk
And,
next here.
Yep. Nick, in the meantime, can you please introduce Dr. Jeremy?
Yeah, for sure. Thank you for your talk, Dr. Halim. Up next, we have Dr. Jeremy Smith. He's a professor from Brigham's and Women's and the medical director for the Brigham's Women's Orthopedic Imaging and Rehab Service. So I'll pass the microphone to you, Dr. Smith.
Thanks very much. All right, so my charge today is to talk about posterior malleolus fractures, and I have no relevant disclosures. So as we know, posterior malleolar fractures can take have variable different characteristics, so size, shapes, etc., and I'll talk about that. So the goal today is to talk briefly about anatomy, mechanism of injury. I do want to talk about classification systems because that has guided my treatment algorithm for how I think about these injuries, imaging, and then some surgical technique tips and how I've kind of come to think about treating these injuries. So first off, we have to think about our anatomy. We have to think about stability. So of course we have osseous stabilizers. We've talked about this a lot this morning and we all know this, but we also have these ligamentous stabilizers, and Daniel showed a similar slide. So when we're thinking about the posterior malleolus, we're of course thinking about the syndesmosis, which restricts in part external rotation. So we want to think about in particular the PITFL and the inferior transverse ligament. So in blue here, this is an axial MR image from a patient of mine, and that's the inferior transverse ligament. So that's actually showing a connection between the tibia and the fibula, particularly at the posterior malleolus. And then as we move a little bit more superiorly, we see the PITFL, and that's shown circled in yellow. So these are real structures that connect the posterior aspect of the ankle, and they're relevant when we're thinking about these injuries. So these are typically posterior malfractures or rotational injuries. They can be isolated, of course, and associated with other bony injuries. The higher the energy, typically, the larger the fragments, although that's not entirely 100% true, but that's a general teaching. So when we think about classification systems, so Dr. Halim showed some images as well of the Logie-Hansen. So when we start incorporating posterior malfractures into this system, so published in 1950, so what we start to see is with the external rotation injuries. So the SER3s, the PER injuries, that's when we start to see posterior malleolar injuries. So mechanistically, it's really more of an external rotation mechanism than some of the other ones as described by Logie-Hansen. But I also want to mention the Haraguchi classification and the Mason-Malloy classification, and I'm going to show those now. So Haraguchi in 2006 published in JBJS a different classification based on CT scan. So looking at CTs in 57 patients and basically classified it into 3 fracture groups. So there's the type 1s, which were the most common. These were posterolateral oblique fractures. Type 2 had a medial extension moment to them, and the type 3 were a small shell fracture. And then more recently, Mason-Malloy from England published, looked at a series of 121 patients with CT scans, and they revised essentially the Haraguchi classification. And this is what I've sort of come to use for as I'm thinking about these injuries. So so just to review this, so type 1s in the Mason-Malloy are small extra-articular fragments. So these are these shell fragments off the back of the tibia. Type 2s are a posterolateral triangle fracture, and type 3s involve the entirety of the posterior tibia. So these are essentially a posterior pilon variant. So, all right, Mason-Malloy, so they were from Liverpool, home of some excellent soccer or football, as many of you know it as. And so here's what this looks like graphically. So type 1s are small extra-articular fractures. Type 2s, again, that posterolateral triangle. and they distinguish between a type 2A and a type 2B. So 2A has just that posterolateral triangle, whereas the 2Bs have a secondary fracture line with a posteromedial fragment. And then type 3 are those posterior pilon variants, which is really a transverse posterior tibia fracture. And they proposed a mechanistic description for how these injuries occur, which is really an external rotation moment where the talus externally rotates, and that's shown in the graphic below here, and pushes on the fibula and then causes the fracture posteriorly of the posterior malleolus. So these authors are using this classification system. They believe it's a mechanistic description of how these injuries occur. I would also point out here on this image, this cartoon, the side view, the lateral view of these fractures is very difficult to tell whether these are smaller fractures or larger fractures, and that's true with plain X-ray, obviously. So it's difficult to assess fragment size. Often we underestimate the size, and I think it's pretty well accepted that CT is the gold standard for imaging for posterior malleolar fractures in terms of understanding the pattern of injury. So how about treatment? So traditionally, and this is what I was taught, is that you treat the posterior malleolus if there's more than 25 to 30% of the articular involvement, and that's when we operate on these patients. But if we look at several systematic reviews, again, these are published in 2016, generally speaking, patients with posterior malleolar fractures have poorer outcomes, and it seems that the outcomes are not related to fragment size, but rather seems to be more related to joint congruity. So maybe this challenges this treatment recommendation, which was dogma when I was going through my training, which is we treat these if you have 25 to 30% articular involvement. This is a study published in FAI in 2023, and these authors looked at different approaches for managing or looked at studies that evaluated management of posterior malleolar fractures. So this is a systematic review, and what they did is they compared outcomes with patients treated with open reduction internal fixation versus closed reduction internal fixation, and that's that central forest plot there. And they found that across the board, there were superior outcomes in patients treated with open reduction internal fixation versus closed reduction internal fixation. And then they had a separate analysis, which is that forest plot at the bottom here, looking at ORAF versus untreated patients, meaning the posterior malleolus was left untreated. And similarly, they found superior outcomes in those treated with open reduction internal fixation. So I think these data and prior published studies push us to think about treating, maybe being a bit more aggressive in terms of how we treat posterior malleolus fractures and what our indications are for surgery. So again, the traditional dogma, 25 to 30% articular involvement, I would challenge that and say that now we're moving more aggressively to fixing these with open, or as Chris Miller would say, arthroscopic approaches for addressing these. And I think if you have more than 10% of the articular involvement with step off, then it's reasonable to consider treating these operatively. And certainly if there's evidence of instability, residual instability, syndesmotic disruption, talar subluxation, or failure of close treatment, these would be other reasons we might treat these patients operatively. And when we think about our goal of surgery, really the goal is to provide stability to the tibio-talar joint. We want to provide stability to the syndesmosis, and we want to provide articular congruity with regards to these posterior malleolar fractures. And so this is this Mason Malloy authors, and I found this to be really helpful in terms of how I think about treatments. This was published in 2019. And so they use their classification system here, 1, 2A, 2B, and 3. And they describe different approaches for managing these injuries. So for type 1s, which was that posterior shell fracture, they treated these patients with syndesmotic fixation. So the supposition is that the fracture is too small in order to meaningfully fix the fracture with hardware, so you do it secondarily with syndesmotic stabilization. Type 2As, which are those posterolateral triangle fractures, they treated with a posterolateral approach with open reduction internal fixation. The 2Bs, and this is important, they would treat with either a dual approach, which is a posterolateral and a medial posteromedial approach, or a posteromedial approach in isolation to address these. And importantly, and they show this in this cartoon here, they recommend keying in the posteromedial fragment before the posterolateral fragment so that you don't accidentally reduce the posterolateral piece, and now you've posteromedial pieces out of position. And then the type 3s, they would treat those with a posteromedial approach. And so this has really helped me and has been an approach that I have used in terms of thinking about how I fix these injuries. When they looked at their outcomes in this same study, they found that as compared to a previously published study by Roberts, where patients with posterior malleolar fractures did relatively poorly, when they applied this framework for how to treat these and were more aggressive with treating them with ORAF, that their patients did better, and that's shown here with the Olerud-Molander scores that were improved. So here are those 3 different approaches. So there's a medial posteromedial approach, there's a posteromedial approach, and a posterolateral approach. You can safely get to the posterior malleolus through any of these approaches. You obviously have to know your intervals. And you can combine these approaches, as I mentioned, particularly the posterolateral and the medial posteromedial, as needed to address the posterior malfractures. So when we think about these injuries, I think it's important to remember our goals. So again, we want to provide stability to the tibio-talar joint. We want to provide stability to the syndesmosis, and we want to restore articular congruity. These are all patients of mine, different hardware patterns. It doesn't particularly matter as long as you're achieving these goals with regard to what you use. So take-home points. So think about stability. We want to think about the bony architecture and the ligament integrity. CT scan is essential for assessing injury and planning. Know your goals when you go into these cases and you think about these injuries. And I believe treatment should be individualized based on fracture morphology. And again, I've found this JBJS article to be really helpful in terms of thinking about how I approach these injuries. Here are my key references, and thank you very much.
Thank you, Dr. Smith. So the session is now open for questions. And Nick, can you check the chat box if we have questions? So my question to Dr. Miller. So Dr. Miller, in what percentage of your cases where you do an ankle arthroscopy for an ankle fracture, have you found an actionable lesion? Meaning you had to do something other than the ankle fracture? And are there any specific ankle fracture patterns where you would scope them, or you would just go in and scope all the ankle fractures?
Yeah. So, I mean, there's been, and I think much like the studies I showed, you know, well over half have something that I'm doing. Most of those are debriding something. So taking loose bodies out, or, you know, I've always been impressed every time I put a scope in there. I see something more often than I think I will, just based on the x-rays. And so I do it more and more. And, you know, I think if you have a dislocation, if you have like a syndesmotic disruption, if there's significant displacement, then those are all ones that I preferentially scope. But I think it does play into the resources that you have available. So if I'm at the main campus, like, I just can't scope there. Now, maybe that would mean that I would be more likely to do a little arthrotomy somewhere, or work through the medial mal and make sure I flush out any loose bodies that are in there, but I won't be able to necessarily treat a cartilage flap, for example. So it's more often than not, I'm seeing something when I'm in there and doing something about it. So increasingly more and more. And if I can do something, if I can repair the deltoid, for example, if I can address this syndesmosis, then I feel like I'm getting more bang for my buck, so to speak.
And a follow-up question to that. So do you use your standard scope, or you like the needle scope?
I use a standard ankle scope. You can do anything. I mean, you can use in Europe, my friends over there use standard fluoroscopes. So you can do any scope that you want. I think the needle scope is another good option, particularly if you just want to do a really quick look. If you're going to try to do a lot of work in there, you are somewhat limited by the amount of flow that can go through the cannula. But there are people doing that too, and I think it's reasonable.
Thank you. I think I can see on the chat, Dr. Eric Blumen has a question. Yep, please go ahead.
Thank you. Can you guys hear me? I'm on a workstation without a camera, so I'm sorry about
yes.
that. Okay.
Yep, we can hear you.
I guess I have a two-part question, and it's for Dr. Smith and perhaps Dr. Kwon can also chime in. It's two parts. The first part is, Jeremy, you presented the Malloy classification and mentioned that they either imply or directly state that there's a mechanistic explanation for their classification system. And I'm wondering, with some of the work that John has done looking at, seeing direct video representation of injuries and with implied mechanisms, whether you feel that that's a very strong correlation, like there is a true mechanistic correlation between what happens and how they're explaining it, or whether it's more akin to what John has found with the SER and other fracture patterns.
Yeah, thanks, Eric. Reading through their paper where they present this classification system, Mason Malloy. So what they're proposing and seem to believe is that when these injuries, it's an external rotation moment, as I mentioned, and it's actually a push-off fracture of the posterior malleolus, as opposed to an avulsion injury, which is how Haraguchi described it, of the PITFL. So that's what they're trying to demonstrate with the graphic there, just to clarify. And that's how they kind of came to that cartoon with the push-off. And John, I'd love to hear your thoughts on YouTube and and fractures.
Yeah, thanks, Jeremy. I agree with you 100%. I mean, we classically have thought about that small posterior malleolus fracture as an avulsion, right? But in order for that to avulse, the fibula would have to be going the whole opposite direction, right? So how does it avulse if it's external rotation? And I agree. I think to Jeremy's point and Mason Malloy's point, it's probably pushed off and fractured. I've thought a lot about mechanisms, and I think Lockie Hansen was correct for pronation injuries. I'm not sure if he was correct for supination. But the thing is honestly, in my daily practice, it's honestly more theoretical and somewhat irrelevant. Every patient, I stress their syndesmosis, just like other people like Chris and Umgod said. I stress the deltoid by external rotation and valgus stress. And so, while I think it's important to understand the mechanistic theories, in practice, when I'm in the OR, I still kind of check everything and don't necessarily rely on the theory to tell me, well, the syndesmosis is likely fine or the deltoid is likely fine. I just go check everything. So,
thank you guys. That's great. And the second part of my question was, clearly these fractures have more than a articular contribution in terms of stability of the syndesmosis and the mortise in general. I've certainly come into situations, both for cases of my own and other people's, where a posterior approach has been taken for somewhat small fragments that have led to significant stiffening and fibrosis in the posterior capsule. Can you guys give us some pearls as to how to decide whether and when to go back there for smaller fragments that may or may not have any articular contribution, and when, if ever, do you forego posterior approaches and maybe just fix the fibula into the incisura in cases where you're worried about syndesmosis instability, associated syndesmosis instability?
Eric, thanks. Really excellent observation and point, and something I've seen as well. And I think it may have to do with dissecting the FHL off of the back of the tibia. I've wondered if that's why these patients get stiff. And interestingly, I found them to be more stiff in plantar flexion, somewhat counterintuitively, than dorsiflexion postoperatively. I think it's an important question, and my sense is using that Mason Malloy classification is truly the shell ones that are going to be hard to get a plate on or any meaningful fixation in. Then there's really no reason to go to the back. But if you have a young patient and you've got a sizable piece, and again, I'm using 10%, which is smaller than the what I grew up with as my cutoff, I'll typically go around the back and formally reduce it and put hardware in. Of course, I'm interested in others' thoughts on that as well.
Thank you. And in the interest of time, I think we can have one more question before we close this session. So any more questions? I have one for Dr. Amgad. So Dr. Amgad, you very beautifully showed that the spring ligament is a continuation of the deltoid ligament. And Lyndon Mason recently came up with this very interesting concept. So up to 30% of ankle fractures in their series also had a subtalar joint instability, which they attribute to rupture of the spring ligament. So what's your thought on that? And in your clinical practice, have you come across any such cases? Also, the question is open to the other experts as well. Yeah.
Yeah, I think subtalar instability is something that sees us and we don't see it. As they say, you know, the mind does not see what, or the eye does not see what the mind does not get. So you have to be cognizant about it. And a lot of times, in my humble experience, the subtalar joint tends to stabilize itself with immobilization. And these intricate small ligaments tend to heal. And it goes every now and then when you see that significant patient starting to swing into valgus because of the subtalar instability. Is it part of our routine practice? As of now, I don't think it is. I think just by the inherent nature of this ligament to heal by itself. But is there a role for us to scrutinize and detect it? I think that would be a very interesting research question that we might look into, so that we are able to catch these failures that we just presented with a chronic deltoid / spring deficiencies that would result in compromised results later on. So that's a very good question. It's a very interesting research question.
Thank you.
Hey, Sid, can I answer that as well? So I agree with Amgad. You know, I think the question is injury versus instability of associated ligaments, right? So, you know, there's, as you know, renewed interest and thought on ATFL injury, right? Capsular injury with ankle fractures. And you do a lot of ankle fractures and you pull on them, you see it, right? But not many patients come back complaining of instability after their ankle fracture. Now, I think that is an interesting thought itself, because our patients after ankle fracture with ATFL injury, are they actually having instability? But we're not asking them, right? When we see a patient with a chronic ankle sprain, we always ask them if they have instability. But we don't ask our trauma patients, our ankle fractures, are you having instability? So maybe they're not telling us because we're not asking, and they are having some subtle injury. But, you know, I think elucidating these injuries that we just traditionally haven't thought about is pretty cool.
Thank you, Dr. Kwon. And with that, I hand it over to you, Dr. Kwon, for the next session.
All right, great. I know we're running a little bit behind, but we'll just start our last session, which is what else aside from the fracture. Our moderators are Lercan, my friend and colleague, associate professor at Koç University in Turkey, and our own Dr. Atta, a physician scientist extraordinaire. So take it away, guys.
Thank you, Dr. Kwon. Good morning again, everyone. Welcome to the third part of the presentation. We've heard excellent talks this morning on diagnosis, imaging, and treatment techniques. We'll now shift a little bit our focus to critical considerations beyond the fracture itself, the implants, rehabilitation protocols, and associated injuries. Our first speaker, Dr. Bedri Karaismailoğlu, is an associate professor from Istanbul University-Cerrahpaşa. He will share his insights on the use of various implants in ankle fractures. So without further ado, Dr. Karaismailoğlu, the floor is yours.
Thank you so much, Atta and Lercan. So it's my really great honor to be participating in this symposium, which is a really great way to see the old friends and also get to know the new friends. It's always a family in the FARIL. So anybody joining the FARIL, I just feel like somebody is joining our family. So
it's really a great pleasure. So I will try to go over what kind of implants that we can choose during the fixation of our ankle fractures, buttons, nails, and plates, we have called it, or we can call it like something else. So I'm not sure if I will be able to give any kind of exact answer to this question, but I will try to give you some insights because we know that the implant itself is not the only thing that we should consider, and nothing really this talk. So we are in the jungle of different implants. We all see these different materials, and they offer different advantage, and they may possess different disadvantages. So, but we know that the only answer that we need to find is not the ideal implant, but also it should go in hand by other factors, which are maybe the even more important parts. So we are trying to provide biomechanical stability. We are trying to get a good functional outcome. We are trying to have less complications, and also it needs to be cost effective because if you want them to be be able to use in other patients, so without really actually damaging our healthcare system. So when we say ankle fractures, there are two major subtitles that we can talk about. One of them is like rotational injuries, like bimalleolar, trimalleolar, or we can have like high impact, high energy injuries like pilum fractures. So let's go over some of the parts of these fractures. So for medial mal, I think it's the evidence, the literature is the most evident, and also we don't have that much controversy around medial mal. So mostly screw can work great if it's only the medial mal, and then we can have it cannulated, we can have it headless, also in some cases with maybe less like a smaller parts. We can also use tension band wire systems to be able to fix. And also we have to make sure that if the fracture line is going up above the metaphyseal location, the buttress plate is a must. Just the screws will not be able to hold it in place. If you go to lateral mal, so we start to have some more different kind of materials that we can use. So this time we have conventional plates. They will really perform good if it's done in a correct way. But we know that in some cases we might have some small parts, and we might have some osteoporotic patients. So the locked plates locking plates will be really a great alternative, which are actually more expensive. So we have to balance what we use and what we don't without risking the patient stability. We also have intramedullary nails, fibular nails, which is even getting more popular and popular each day. So we are still we still need some kind of evidence for broader use, as we know there might be some limitations for the reduction, especially if the shortened fibula and displaced fibula are there. But we know that it's a really great way to make it minimally invasive. If we have any soft tissue problems, if it's elderly, I think it has a great potential, and maybe in the future we will be also doing this for more kind of fractures. Syndesmosis is really a big part of the ankle fractures when we look at the literature. So the questions that we can ask are like many. It's not only the implants. So the thing is, like, we can fix it with better screws or suture buttons, or we can do them hybrid using both screw and suture buttons. But so the industry is actually crazy about it and always comes with like a new designs, different designs, buttons inside screws and some kind of other materials. I think that's the most kind of exciting area of the ankle fractures. Since syndesmosis, we have not understood it yet, and it's like the ACL of the knee surgeons. We still love to do many research about it and try different things. So for posterior mal, again, it's more straightforward. We need to fix it, but there are many other questions that we ask, whether it's from anterior to posterior or from posterior to anterior, as we already discussed in our previous lecture. So the plating might be a good option when the posterior mal is a small that cannot accommodate a screw, or if it's too big. For pylon fractures, it's so a la carte surgery. So you need to just really analyze the fracture lines and be able to give the most stable construct with mostly plates. But you can see that since it's a really a high impact, high energy injury, so you can have really bad soft tissue. So again, even some kind of external fixations like circular frames can be a definitive treatment for some patients. And I think intramedullary nailing is really an important alternative in old and less active patients if the fracture is really really in a bad condition, like you have many particles in an ankle that you cannot construct. I think intramedullary nail has a good chance that it might help you, and I will give some examples on that. So can we compare these implants to each other? So we have many studies, even randomized control studies, suture button to screw, plate to external fixator, nail to plates. Yes, we can compare them biomechanically, we can compare them clinically, and we can use cadaveric specimens. So what most of the studies, if you go to conclusion, we compare these two techniques and the results are similar. So I think it's also the problem with having a really good clinical study. Like it's not easy to have a randomized control study in big numbers and really homogenized groups, and also getting a statistically significant difference is even hard, even though you might get some difference. So I think that's something that can also boost our desire for doing more research, because there are many still unanswered questions. I'll just go over a couple of examples and kind of wrap up my talk. So this is a distal tibial fibula pilon fracture. It's an open fracture, as you can see. So we don't go straight forward to plating. We just we first externally fixate it and then stay some time for the soft tissue to heal. As you can see, like there also the anterior part is completely detached in the articular surface. And during our definitive surgery, you can see that the anterior part was completely separate from the rest of the fractures, but we had to put it back and pray that it will unite. So at 2 years, the patient was able to do whatever he wants, because he was working in military and was not restricted. But this is a good story, but you can have bad stories also. So this is the 56-years-old male. As you can see that the joint is really crushed, and since the patient came after just the previous patient, so we thought that we can reconstruct this in a good way, and also this patient was diabetic, and so we went to the surgery and we made an external fixator first, and then after waiting some time, we have done a surgery like this, which so the fractures are not well stabilized. Some of them are not that much stable, as you can see, but the joint congruency was kind of okay. But still, if you want to put that much of plate into this ankle, you need many incisions, which we use like 3 incisions, and that you can see that skin is like crying out. you can see that the soft tissue is really bad, and past of 6 months, the patient is really painful and still asking for help. So this is another plum fracture. This time we have learned our lessons, and we have put an intramedullary nail. The patient was happy and he could bear weight at the first day. And this is another pilum fracture operated elsewhere, and nice joints, but again, infection and infected non-union. So we have planned doing a resection and then segment transport and distraction osteogenesis, and then after that we have nailed it. So to answer the first question that we asked, what implants should we be using? You can do plates, you can do tight ropes and fail, you can do nails and fail, and you can do both like plates and nails and still you can fail. So it's not the way, either way you can succeed or fail. It's how you control, how you well adapt to the conditions you face. So whatever you do, you need to act wisely and consider the end. So this is a jungle of screws which are fixed in the forefoot and in a Charcot patient, but we have to work with nature, not fight with it. As you can see, nature can also do a really great job, like a sports car. So we shouldn't be fighting with the nature. So we shouldn't be on the wrong side of the pillar, and we shouldn't be also against what our mentors and seniors tell us to do. So implant choice should be evidence-based, cost-conscious, and patient-specific. So reducing implant-based and avoiding unnecessary expensive implants is part of modern value-based orthopedics. So this is just a last remark. Is future be or something, because we are seeing a lot of biointegrated, biocompatible things, but we have still time to explore these. And thank you everyone for inviting me again. And it was a really great pleasure to have the first FARIL International Symposium in Istanbul. And we really had a great time. I hope we can do it like in different centers again and again. Thank you so much for the invitation.
Thank you, Dr. Karaismailoğlu, for that excellent overview of fixation options. Our next topic addresses another critical decision point. When do we allow patients to bear weight after ankle fracture surgery? Traditional protocols have been conservative, but recent evidence suggests earlier mobilization may be beneficial in select cases. Dr. Siddhartha Sharma from Postgraduate Institute of Medical Education and Research in Chandigarh, India, will present weight bearing and rehabilitation. Should I let them walk right away? Dr. Sharma brings both clinical expertise and research perspective to this evolving area of practice. Floor is yours, Dr. Sid.
Thank you, Lercan. So it always feels like coming home, and this feels like our 6 a.m. meetings. Thank you, Soheil. Thank you, Team FARIL. It feels good to be part of this family. So I have no disclosures or conflicts of interest relevant to this talk. And when I thought of this talk, weight bearing after ankle fractures, should I let them walk straight away? Well, the answer could be yes, but maybe no. So I thought, let me break it down into 4 important sections. So when do we allow weight bearing? How do we allow it? What about the range of motion? And what about the modifiers, right? So if you think in terms of a day 0, it could be the day of injury of the ankle fracture or the first post-operative day. Until the time the fracture unites, should these people walk partial weight bearing or full weight bearing? Should we put them in a plaster cast or a walker boot? Should we have active or passive range of motion? And then what do we do with patients who have diabetes, osteoporosis, associated injuries? Because we are seeing these more commonly now, right? And the treatment in India, where I work, may not be the same as in Turkey, where my friend Bedri is, or in the US, right? So I thought, let me show you some cases to put things into context, and then we can discuss the weight bearing as we see these cases. So this is a young male who comes in with a twisting ankle injury. You see a Weber B fracture. You don't see a medial malleolus fracture, right? So we do a gravity stress view just to see whether it's a stable Weber B injury. So this patient has no medial tenderness, no medial ecchymosis, meaning no signs of a deltoid ligament injury. So we don't really have a weight-bearing CT. We would love to, but a non-weight-bearing CT shows you a congruent syndesmosis. So in this case, we think that this is a stable Weber B injury. And these are the cases where you can manage these patients full weight-bearing in a short leg cast. Where is the evidence to support this, right? So this is a beautiful randomized control trial. I think it's the largest trial on this subject, known as the CrossPath trial from Australia, where they showed that surgery is not superior to non-operative management. In fact, surgery for stable Weber-B fractures has a higher complication rate. So there you go, you have level 1 evidence to support non-operative management. And then very proud to say that work out of our lab, FARIL, headed by Matthias, also showed that if you have a congruent Weber-B ankle fracture, it does not affect the tibio-talar contact mechanics. These are the patients that you could manage non-operatively. So we put this patient in a short leg cast. The BMI was on the higher side, so we decided to continue the cast for 6 weeks. The CrossPath trial, people say that you can remove the cast at 6 weeks and just let the patient walk without any protection. But in India, in my clinical practice, we continue the cast or the walker boot till we see a solid fracture union, right? And we only allow active range of motion after the cast has been removed, which is roughly at the 4 to 6 weeks time frame, right? So there's the summary of the protocol. We allow full weight bearing in a cast, transition to a walker boot at 3 weeks. We get check x-rays to see whether or not that medial clear space is widening, and we can start active range of motion at 3 weeks if the ankle is congruent. Now contrasting another case, young male, another one with a twisting ankle injury. This is a slightly higher, this is a Weber C fracture. You see that the medial clear space is widened. And when we do an intraoperative stress view, you see that everything is unstable. The syndesmosis, the medial clear space is opening up. So we plated the fibula, put in a syndesmotic screw. Well, the medial clear space was still widened after this, and Dr. Kwon discussed about this, right, in our discussion session. This patient also had a fibular-sided ATFL avulsion, right, that was also noticed. So in this case, we decided to do a deltoid ligament repair. And as Dr. Amgad showed us, the superficial deltoid, as you can see, is mostly intact. It was stretched out. But what you're seeing with the forceps now is the avulsed part of the deep deltoid ligament. It avulsed from the medial malleolus. We were able to put in a suture anchor and repair it. That's how it looked like. And what do you do with your weight bearing in this case, right? So we have concerns of a medial soft tissue injury. Well, the medial collateral ligament is injured, so we would not want a range of motion early on. So this patient was put in a short walker boot, a short leg, a cast to begin with, and then transitioned to a walker boot at 4 weeks. We waited 4 weeks for that deltoid ligament to heal, active range of motion of the ankle at 4 weeks, and full unprotected weight bearing when the fracture united, which was around the 3 months mark. Now we keep going to a more severe type of an injury. So this is a 45-year-old male who fell from the stairs, has a typical Logie-Hansen pronation abduction injury. We see a large Chaput fragment, a fibular comminution, right? So in this case, we fixed the medial malleolus. You see we did an anterior lateral approach, a large Chaput fragment with a plafond impaction. And mind you, this will be a concern when we talk of weight bearing later on. So the Chaput was also fixed. We did a bridge plating of the fibula, maintaining the fibular length. We used a distractor. The syndesmosis was unstable, so we had to go in and put in a syndesmotic screw. The Chaput and the fibula, we used one single approach, and not surprisingly, we had some wound issues at the 10th day post-op. So in this case, again, we put a cast for wound healing, right? The wound resolved later on. We transitioned to a walker boot at 3 weeks, started off with active range of motion at 3 weeks, but because this patient had a plafond impaction, we waited for a full 3 months for the fracture to heal before we allowed them full weight bearing. So what does the literature say about this? So early weight bearing in ankle fractures, which is defined as weight bearing within 2 weeks post-operative, has better functional outcomes in the early post-operative period. However, there is no difference at 6 to 12 months, and importantly, there is no difference in complication rates. What about the range of motion? So if you start a range of motion before wound healing, as they saw in this systematic review meta-analysis, there were 3 times higher chances of complications, right? So it makes sense to let your wound heal and then start off with the ankle range of motion. Now, what about unprotected weight bearing? Can I let them walk without a cast or without a walker boot? Well, unprotected weight bearing was shown to have a higher wound complication rate and no difference in functional outcomes. So again, it would make sense to use some kind of a protection, a cast or a walker boot early on, and allow them partial or full weight bearing depending on the fracture pattern and the fixation that you have achieved. Now, when it comes to range of motion, how much range of motion can you allow? And this very interesting study published in the Injury recently, it showed you that for a 4.4A3.3 fracture, which is roughly a Weber B fracture, and if you were to accept a 150 micron displacement at the fracture site, which is within the realm of a micro motion, you can safely allow 10 degrees of dorsiflexion and 13 degrees of plantar flexion in the immediate postoperative period. Of course, as the fractures start to unite, they become sticky. You can permit more and more range of motion, and it's always better to allow active range of motion. Now, a word of caution about the geriatric ankle fractures, right? So in this study, they showed that if you had early weight bearing in low energy geriatric ankle fractures that were fixed well, there were no increases in hardware failures and no increases in complications. So you can even allow your geriatric patients with stable fracture patterns to walk early. And now it's a little tricky part. What about these diabetic ankle fractures, which we see very commonly in our practice? So if your patient has a well-controlled diabetes, they are low morbidity patients, it's a stable fracture pattern fixed well, you can allow weight bearing early on, right? Mind you, the complication rate is higher when you compare it to the other subset of ankle fractures. But if you have poorly controlled diabetes, then non-weight bearing may be a better option, as you can see here. Importantly, creatinine is an independent predictor of complications in this group. So the take-home points for this from this talk: early protected weight bearing works well for most ankle fractures. Active range of motion should be done after the wound has healed. For geriatric ankle fractures, you can have early weight bearing, but be mindful of the diabetic ankle fractures, especially the ones with complicated diabetes. Well, thank you so much.
Thank you very much, Dr. Sharma, for the excellent overview. Our final presentation addresses an often overlooked aspect of ankle fractures, osteochondral lesions. These injuries, we know, can be easy to miss initially, but may significantly impact long-term outcomes. Our next presenter is my co-moderator, Dr. Aslan Lercan, Aslan, assistant professor from Kwon University. He will cover this topic. Without further ado, please, Lercan.
Good morning, everyone, and thank you, Atta, for introduction. And also, I would like to thank Dr. Kwon for his kind words. It is great to be here. I'm so honored. So today, I will be presenting osteochondral lesions of the talus. I actually wanted to cover what happens after the fracture as well. So please bear with me. So I have no disclosures to report. And as you know, osteochondral lesions of the talus are commonly associated with trauma. About 93 to 98% of lateral dome lesions occur after an ankle sprain or fracture, while medial dome lesions follow trauma in about 61 to 70% of cases. We also know that ischemia and genetics may contribute to their pathogenesis as well. In imaging, we always start with plain X-rays to look for deformity or subchondral changes. Then we move on to the CAT scan and MRI. Recently, CAT scan has become more favored than MRI because it shows the exact size and depth of the lesion, which is crucial for surgical planning. Van Dyck described two main pathways for how these lesions develop. The first is cartilage edema. As you know, cartilage is nourished by diffusion through the subchondral plate. When edema develops, each step compresses that fluid into the bone, creating bone marrow edema. Over time, this pressure damages the microarchitecture and leads to cyst formation, which means a worse prognosis. The secondary theory, which is more relevant with ankle trauma and fractures, involves cartilage loss and exposure of the subchondral bone. Here again, if we miss the cartilage loss, with each step, synovial fluid gets forced into the bone, causing bone marrow edema and pain for the patient, which decreases the functional outcome. We commonly use the Burns and Hardy and Heppel classification to guide our surgical decisions. In the following slides, I'll show the figures summarizing the surgical techniques for each stage. But first, we always start with conservative treatment, which is rest, ice, no weight bearing, and immobilization. If symptoms don't improve for the patient after 4 to 6 weeks, surgery becomes the next step. And meta-analysis studies show that conservative treatment works in only about 62% of cases. So it's worth trying, but not always successful. The literature highlights some poor prognostic factors like cyst formation, extensive bone marrow edema, and also arthrosis. However, recent work, including our own, suggests that lesion location and the diameter of the tibialis posterior artery may also influence outcomes by reflecting local ischemia. At first, actually, we conduct the finite element analysis and found that different Taylor zones experience different loads during gait. And according to this finding, we conduct the study, and our methodology showed that zone 4, which is a central medial zone, is subjected to the highest loads, especially when the lesion is larger than 10 millimeter. This suggests that more advanced cartilage restoration techniques might be necessary for these kinds of lesions. In another study, we measured the tibialis posterior artery diameter at 3 levels and found that patients who developed Taylor OCDs after ankle sprains had smaller artery diameters, suggesting a vascular contribution to lesion formation. Now, moving on to the surgical options. First, we must decide what we aim to achieve, actually. So if possible, we fix the cartilage, we fix the original cartilage back in place. If that's not feasible, we try to regenerate hyaline-like cartilage, and if not, we at least aim for fibrocartilage to protect the subchondral bone. And these are the topics we will cover today, so let's start. The first one is retrograde drilling is one of the first techniques. Its indications are limited, like the patient should be adolescent with a healing capacity, and the cartilage over the lesion should be intact. In short, we drill some retrograde holes to stimulate stem cell migration into the defect. Although studies are limited, when properly indicated, this method is a promising one. The next is fixation of the osteochondral fragment using a headless cannullated screw. So the fragment should be at least 1 centimeter wide and 3 millimeter deep, which needs to hold the screw securely, actually. This is how the indication is defined. The approach can be arthrotomy or medial malleolar osteotomy, and after identifying the lesion, we place a K-wire and advance the headless screw along it. Here you can see the postoperative CT scan at 10th month follow-up showing successful healing afterwards. The microfracture technique remains the gold standard for smaller lesions. It's easy, it's cost-effective, and yields high satisfaction, but it produces fibrocartilage, not a true hyaline cartilage. And it restricts its indication for lesions smaller than 150 millimeters square. Although recent studies suggest a cutoff at 107.4 millimeters square. So reported success rates vary widely from 20% to 100%. And my mentor also published his own experience confirming its value within proper indications as well. Right now, most of the time, our indication between microfracture and other cartilage restorative techniques is the lesion size, but there seems to be a gray zone between these two thresholds. We might want to look into this area for further understanding. For larger or recurrent lesions, we move to cartilage restoration techniques, mainly osteochondral autograft transplantation. It provides high satisfaction and can be even used in the revision cases as well. However, it carries the risk of donor site morbidity, reported between 6 to 10%, and some studies even up to 38%. And here you can see the lesion exposed to remedial malleolar osteotomy and the graft placements after the surgery. There are vast numbers of studies focusing on osteochondral autograft transplantation with high functional outcomes and satisfaction, which is a really favorable surgical technique for the talus osteochondral defects. So Autolog chondrocyte implementation is another sophisticated method. Cartilage, this consists of two surgeries. At first, you go in there and get the cartilage, harvest the cartilage from the patient during the first surgery, expand it in the laboratory, and later implant it back. Even though it's expensive and technically demanding, it produces hyaline-like cartilage. This slide shows our clinical sequence, actually debridement of the healthy bone, autograft filling, lesion sizing, and shaping of the cartilage, and final cartilage placement. There are a limited number of studies published in the literature, but its success rate is quite high, actually. So another one, autolog matrix-induced chondrogenesis, offers a simpler alternative for this situation. No second surgery is needed with an ability to produce hyaline-like cartilage. As in this figures, you detect the lesion and perform the microfracture, and afterwards you insert iliac grafting and then apply the chondrocyte matrix there. So similar to the studies in the literature, we also shared our experience with this technique and reported a 95% success rate in primary cases, 88% in tumor-related lesions, and 61% in the revision cases. So when we compare these techniques, microfracture and osteochondral transplantation system provide the best satisfaction in properly selected patients. But now we have a new player, the topic technique. Actually, it is called Taylor osteopericostic grafting from the iliac crest. It began with a South Korean study in 2013, where they harvested cylindrical autografts with periosteum and implanted them into the Taylor lesion, achieving very good functional results. It uses actually the same approach as the osteochondral transplantation system, but avoids donor site morbidity. Following studies also supported their claim with high radiological healing and near to non-donor site morbidity. And the Amsterdam group later reported a 100% union rate and excellent satisfaction, making it a highly promising option. In summary, no current technique perfectly restores the hyaline cartilage, but continuous research brings us closer. Cartilage restoration for Taylor OCDs remain a dynamic field, and I hope one day we can truly regenerate the native hyaline cartilage, which will boost the functional outcome. Thank you for listening.
Thank you, Lercan. Thank you very much. And thank you to all the speakers. I apologize on behalf of the whole group that we're a little bit over time because of the technical issue that we were facing. But now we have about 5 to 7 minutes for the discussion. Then I hand it over to Dr. Smith for the closing remarks. Please feel free to add your questions in the chat or raise your hand. So I'm going to go first with my question for Dr. Sharma. You talked about early protected weight bearing, but we know that some patients might be hesitant, especially in special populations like geriatrics. How do you counsel patients who are anxious about walking a recently fractured ankle? And do you think early weight bearing might introduce or reduce fear of falling in certain populations like geriatrics?
Well, that's a great question, Atta, and I know that you've been working a lot on falls in elders. So with elders, actually, it's very difficult to have partial weight bearing, right? So they're either full weight bearing or they're not weight bearing at all. So I think it's so important to fix these ankles very, very well. If you have an osteoporotic ankle fracture, just double your fixation, use locked implants, try to make it as stable as possible. And then I feel no shame in putting them in a cast, right? And allow them. So if I'm very confident of my fixation, I will allow them to weight bear in a cast. They feel a little more protected that way. And of course, you have to counsel them. You have to talk about the dangers of prolonged non-weight bearing. So you could have reflex sympathetic dystrophy, all sorts of osteopenia, right? All of those issues. So I think it has to be a continuous conversation between the patient and the surgeon. But the thing that you can control the most is have a solid fixation on the table.
Okay, that sounds great. Thank you very much. I think Dr. Smith has a question.
Lercan, thank you for your talk about osteochondral lesions. I have a question about osteochondral lesions in the context of ankle fracture, and whether you think about treatment of these injuries any differently in the acute fracture setting versus sort of the more, sporty injuries or isolated osteochondral injuries without fracture. Are you treating them differently in the context of fracture?
So that's a great contribution. Actually, I recently started doing arthroscopy in every ankle fracture. Actually, at first I fix it and then I debride it and get the debris out and check the cartilage. And if it is small, I go with the microfracture first. Try to go with small techniques, easy techniques, and not time-consuming ones. And if it is larger than that, it depends on the location of the lesion. If it is seated in the anterior region, I can perform an arthrotomy and go with the topic, or again with the osteochondral grafting from the knee. But actually, I just wanted to cover after the fracture as well. So that was the reason. Thank you, Dr. Smith.
Great, thank you.
I guess one of the audience, Inderjit, if I'm pronouncing your name well, please feel free to ask your question.
Yeah, hi Atta, hi Siddhartha. Hi Lercan. It was a good talk. So I just wanted to know, so Lercan, do you do arthroscopy post-fixation also? Like, do you wash off the joint? And have you seen any better results? Like you have fixed the fracture, now you go back with your scope and then, wash out the joint once. Do you do that?
Actually, I just go with the fixation first, and afterwards I go with the arthroscopy just to check if there is any debris there and check the cartilage if it is intact. In that position, I also irrigate the fracture side as well.
Okay. So, but in one of the talks in the beginning, we had that somebody said that it is easier to do with the fracture there. So the ankle is, loose. You can use the scope and go around and see the ankle, scope it, and then go back and fix it. So is that way better to look at the cartilage first before you start your fixation, or you fix everything and then go back in and, So which works better?
It is the first step, and you can go directly with the arthroscope and check the fracture and remove the debris there too. I just after the fix, I just want to see if I was able to restore the cartilage there. That's why I check it lately. Actually, this is a recent things that I do. I'm not saying that. I just want to how can I say, increase my experience about it.
Okay, thank you.
No problem.
Please ask your question, Kolach, if I'm pronouncing it.
Okay. I also have a question for Dr. Lercan Aslan. My question is, like, microfracture remains like widely used, but mid to long-term outcomes are often, like suboptimal. Do you think we are overusing the microfracture in acute fracture settings, and should like scaffold-based or chondrocyte techniques can be considered earlier?
That's a great question. What I was thinking is, in the microfracture, you are leaving that area void. So the pressure that is applied to the ankle joint is distributed to the normal healthy cartilage. And I don't think that in time, in long-term follow-up, it might create some decreased functional outcome for the patient as well. But as I said, the new guidelines are suggesting that we need to decrease the threshold for the microfracture to 107.4 millimeters square, which is also saying that the sophisticated methods, actually cartilage restorative methods, are gaining favor, and also they are becoming more successful. So I think we need to stick with the thresholds, and if it is not bigger than the 1 centimeter square, you can go with the microfracture. But if not, you can consider other cartilage restorative techniques.
Thank you for the answer.
Yeah, just wanted to follow up on what Lercan was saying right now. So in the context of an acute ankle fracture, if you have seen an osteochondral lesion, that's your opportunity to do something today. And I feel that doing something at the moment, right, even if it's a microfracture, is not such a bad idea. Right? So you've picked up the osteochondral lesion, and I feel that it's better to do something than not to do anything at all. And maybe for very large defects, you can always come back and, you know, revisit that thing again. But there's no harm, actually. There's no harm done. That's my thought. Thank you.
Actually, with the, for example, in the AMIC method, you can just order a chondrocyte scaffold, and you can do an AMIC in the surgery as well, if you like, if it is too big. You can fill the void with it. So can I ask a question to Bedri? Actually, is it okay, Atta?
Of course, please.
So, Bedri, I was really wondering about which approach do you prefer for pteromalleolar fracture? Do you have a threshold for posterior malleolar fracture to address posterolaterally, or do you fix all of them? What is your experience about it?
Okay, thank you. So I always try to try new things in my setting. So at first, in my residence years, I have thought that it might not that much matter. Then the literature showed us it might matter, like the posterior malleolar fractures. So I started like kind of fixing all of them. Whenever even like an eggshell fracture, I was trying to put a plate on it, at least a buttress plate, to be able to kind of push it. And then I just realized that it's maybe we should be like acting patient case by case basis. And now I can say that for eggshell fractures, I don't try to like kind of lift off all the FHL and kind of provide any reason for stiffness or something. But I do still have a low threshold. Like I'm not calculating like 20%, 25%. Whenever I think that is creating any instability, and if it can cause any kind of joint depression or any kind of reduction problems, I do always go backwards and fix it and try to make it more stable. But I think even in some, for example, if it's a diabetic patient, if it's an elderly patient, I still can leave it without fixation and put some kind of indirect fixation through syndesmosis, which might hold it in place. But we have also shown in a clinical study, in a randomized study, that any step off in the joint caused by the posterior mal, even 1 millimeter, can bring some bad clinical results. That's why I think it should be case by case, should be decided case by case, and then it's not all and none.
Thank you. I'll guess we get another question. This will be the last one. Please, Dr. Sharma.
So this is not a question, it's actually a follow-up to this, and also a follow-up to what Dr. Smith said earlier. So you have a long posterior incision for a posterior malleolar fracture. Part of why it's long is also because you're fixing the fibula by the posterior approach and also the posterior malleolus. So we had a very interesting discussion recently. How about you use a small posterior incision? So take your posterior lateral incision a little bit more towards the center, small incision, fix the posterior malleolus, and then use a long anterior incision or maybe an anterolateral incision to fix the fibula. That also helps if you have a quadrimalleolar fracture, right? So if you also have a large size Chaput fragment, you could do a long anterior and a small posterior incision, and that maybe avoids the problems of those long posterior incisions. It's just a thought. Thank you.
Thank you very much, everyone. Our panel was outstanding. Dr. Karaismailoğlu, Dr. Sharma, and Dr. Aslan. On behalf of Dr. Aslan and myself, I want to thank all of you and all the audience. Dr. Kwon had to log off since he had to see a patient at 10. So I'll now turn things over to Dr. Smith, the co-chair for the closing comments. Thank you.
Thank you, Atta. I again want to thank everybody. It is so wonderful to see such an accomplished group from all over the world here and to hear your thoughts and on these great topics. So this has been really wonderful. I should again acknowledge Soheil and Atta and of course others for their coordinating contributions. So many kudos to you all for this. And apologies that we ran a bit over. As Soheil has noted in the chat, participant certificates will be sent out by email. If you'd like a signed version of that, please reach out, and that can be provided as well. So with that, thank you again, everyone, for your contributions and your attention. And this has been really enjoyable. Have a wonderful day. And with that, I will sign off. Thank you, everyone.